to all the doctors who are present on this ISAR Fertility Catalyst program. And it's such a wonderful evening today to host all the doctors who are available on the call. I, Pallavi More, I head the marketing team here at UNS and at your service. I present you an organization that has a legacy trust of 3 decades in Indian pharmaceutical and nutraceutical market. We market the products that the doctors believe in immediately with the efficacy that we present with the best of the sources that are available in the market. We are amongst one of the fastest growing nutraceutical company in the array of the industry that markets the products to doctors. And with this, it gives me immense pleasure to thank from the bottom of our hearts as a UNS employee and my entire UNS team, thanking on behalf of all of them to Dr. Amit Patki, who's the President ISAR, for giving us this fantastic opportunity to help from a conglomerate like this, where all the healthcare practitioners from the infertility and the fertility segment come together, they discuss, and a consensus can get formed. And a lot of learning, sharing, and caring platform is also open through this format. I also want to thank the Secretary ISAR, Dr. Asha Bakshi, for again giving us this fantastic opportunity. Today we have our chief guest, Dr. Kamini Rao, a very, very famous face in this industry, and I really want to welcome her on behalf of UNS. Welcome, ma'am, to you and our
Thank you.
guest of honor, Dr. Sujitra Pandit, ma'am. Thank you so much for being here with us, and it's a great honor for all of us to have you on this platform. And I want to thank the conveners of this particular program, helping us immensely every day. Dr. Fessy, who is already here. Thank you so much, Dr. Fessy Lewis, for being there with us. And of course, Dr. Anu Agarwal for spearheading all the ideation and creativity for
Thank
this platform.
thank you.
Thank you is a very small word here. And I literally don't have words enough to thank more. And of course, all the coveted faculty who is here today. Dr. Kamath is here, Dr. Ekta Bajaj, Dr. Sheila Balakrishnan, and all the other speakers who are there. We really welcome you to this. I will pass the baton to Dr. Maheshwar, Director, Medical Affairs for UNS, to start this conversation ahead. Thank you so much. Over to you, Dr. Manish, sir.
Sure. Thanks a lot, Pallavi. This is Dr. Manish from UNS. Just want to highlight that this webinar is the 9th in the series of the webinar, the ISAR UNS Fertility Catalyst webinars. And we are literally blessed to have star-studded panel out here, including Dr. Kamini Rao ma'am and Dr. Suchitra Pandit madam. Without wasting time, would just like to brief intro of Dr. Anu Agarwal ma'am. Everyone knows her. She hails from Varanasi and is the director of Vanch Fertility and Test Tube Baby Center. Has several accolades and credits to her. Uh, uh, yes. And we also have Dr. Fessy Lewis, sir. He is a professor and HOD at Department of Reproductive Medicine and Surgery at Amrita. And he has several attachments as well as several publications as well as awards to his credit. With this brief introduction, I'll pass it on to Dr. Fessy Lewis, sir, for further proceedings, sir.
Good evening to all. First of all, let me thank and we are grateful to ISAR President Dr. Amit Patki and Secretary Asha Bakshi for this wonderful initiative. And also, as you all know, that UNS has been partnering this. And 9th month we are having, each month we are focusing on one topic. And today we have all about genetics. We had a topic of endoscopy. We had topic about medical male infertility. We had about PCOS, like that, all focus topic related to infertility. Basically, our pattern is two talks by expert with experts in the field and panel discussion about the cases related to that. And as an icing on the cake, we have today our past president, Kamini Madam, is our past president, Kamini Madam, as a chief guest, and our ever guiding invite for past Foxy President Suvitra Pandit Madam as the guest of honor. Dr. Anu has joined but had to go for a short break because of one emergency case. She will be joining back. With this, we will set the ball rolling. First, we will call our President Amit Patki could not join. So he doesn't need introduction. So we will take the blessings from our secretary, Dr. Asha Bakshi, who is the lead consultant, Asha Bakshi Fertility Center associated with Motherhood Hospital. And she is the member of Executive Committee of ICC RCOG West Zone, founder chairperson of Maharashtra IAGA and Madhya Pradesh ISAR, and member advisory committee of PCB.
Fessi, this is enough. Thank you. Thank you. Thank you very much, Fessi, for inviting me. And I would like to congratulate you and Anu for doing such a wonderful webinar. And this is a particular webinar which is not just for the infertility specialist. I think it matters to everyone, to all the obstetricians, gynecologists, infertility specialists. So, and there are so many queries every day. Every day you get the patients and you want to know what test to do, which one to do. And I'm sure all these queries and what is the latest literature, all these queries will be solved by esteemed speakers like Dr. Mohan Kamath, Dr. Fiona, and Dr. Apurva Pallam. And it's really a great moment that today we are so blessed that we have Madam Kamini Rao with us. And Madam, lots of regards to you and keep blessing us. And then Dr. Suchitra Pandit. And it's really nice to have people from infertility as well as from obstetrics. And they both are going to give us the blessings. So that's really nice. And I would like to again thank UNS people, Pallavi and Dr. Manish Garg and all, because you are so active in academics, and that I have witnessed in past few webinars as well as in the master classes that you have done. And it really shows that it's not just the marketing, but you are really interested in academics. So thanks a lot for the same. And I think we should continue with the webinar. So once again, I welcome Madam Kamini Rao and Madam Sujita Pandit. Thank you.
So next, we welcome our Chief Guest Kamini Rao Madam. Madam doesn't need any introduction for any, not only ISAR or any Foxy member of India. So Madam is the co-founder and chairperson of Medline Academics, and she's always associated with academic knowledge sharing platform, and co-founder of Medical Director of Kamini Rao Hospitals. And she is a Padma Shri Award winner in 1914. And Karnataka State Award, Rajyolsi Award, honored with the Karnataka Vaidya Ratna Award in 2021, Lifetime Achievement Award by Karnataka State OBG 2021, Kambagada Award for Outstanding Services Achievement in the field of medicine, honored with the BC Roy Award from the Shimoga District Unit of Indian Medical Association, Lifetime Achievement for IVF and Fertility Care. I'm not reading because it's a big list. We like to hear from you, Madam. Over to you, Madam.
Thank you. Thank you, Fessi. First and foremost, I would thank ISAR for having such a wonderful series of programs, and also joining hands with pharmaceutical industry. There are two sides of the coin. The academicians as well as the pharma go hand in hand in bringing in wonderful programs that can reach across barriers to youngsters and seniors like us, because it keeps us updated with the latest. And because of this fact that I have seen so many such webinars taking place, but these focused webinars, which I'm sure that has been a brainchild of Anu's as well as Fessi's, I think that this goes a long way. Rather than having everything under the sun, then, it loses that sheen. I'm very happy to see that recurrent pregnancy loss and this kind of program, that the more you know, the less you know. And the more you study, you understand that there is even more to learn. And I am very, very happy to hear. I saw the program and I saw that there are very many new faces on the horizon. And that means that there is so much of opportunity given to youngsters to participate. And this is what I had always wanted. And this happens to be the Silver Jubilee year of Yuva Foxy. And what better way than to see all youngsters coming in for all these, focus programs that I'm seeing, and I'm really blessed to participate in this. Forget about blessing you people. I need all the blessings because I am seeing youngsters coming forward and giving the latest in the subject, and I thank the organizers for all this that they have actually brought to the table. And believe me, this program is going to be a wonderful success. And along with Suchitra Pandit and myself, I think this is going to be a fantastic program. I wish you all the best.
Thank you, madam, for that words of wisdom. And next, I invite our guest of honor, so none other than Professor Sujitra Pandit, madam. Madam, as you all know, was a Foxy representative to Suffolk now and associate member of FIGO Ethics Committee and co-chair of NCD Committee of Suffolk, South Asian Federation, and international representative for Organizational Justice, chairperson of AICC RCOG 2017 to 20.
Bessie, that's okay. We'll go ahead.
Okay, ma'am.
Thank you very much. I would say thanks, first of all, to Dr. Amit Patki and Dr. Asha Bakshi for the opportunity. And, I should congratulate them for giving Anu and Fasi the opportunity to go ahead and do this ISAR Catalyst program. And I couldn't agree more than what Dr. Kamini Rao has just said. A focus program always teaches you much more. And as I see, there are two very interesting topics where PGT, where are we? And POC is when exactly should you do it for RPL? Because some of these are the burning issues and everybody needs it in their practice because time and again these situations do come up. And I'm also seeing that, when you have got something new, of course, very rightly, by attending these focus webinars, you come to know more and more. But also, it's an opportunity for the younger people to read up and come forward with the ideas and then discuss it at a forum. Sometimes in conferences, you get lost because there are too many people. But in these focus group meetings, you can learn a lot more and impart knowledge to the others also. I did see Sheila just a while ago. Hello, Sheila, and hello, Dr. Bajaj. And thank you once again, Fesi. Carry on the good work, and I would like to congratulate you for one more thing because you've taken over as the president of your Kerala Federation, which is again a very big gap
Next year,
that
madam,
you're
next year.
next year. But you're the president elect, so you're already in
Yes, yes.
training. So that's a big responsibility. And I won't come in between you and the program now. And thank you once again for inviting me. And though I am not directly doing IVF, I do infertility and RPL. So it definitely interests us to learn something new about these topics. Thank you very much.
Thank you, madam. I think with this, we will go to our scientific session. And before introducing the chairperson, I like to, first of all, thank Professor Mohan, who is a good friend of mine, who agreed to come here because he is always like to clear the doubts and interact with the people. So he always, he was just now also he is very much interested in interacting and clearing that. That's why he's more interested in physical meetings. So to introduce him, he is a professor and HOD of reproductive medicine at CMC. And he's awarded FRCOG by RCOG in 2023, Commonwealth Fellow of Reproductive Medicine UK in 2012, and completed Master Clinical Trial MSc from University College London in 2023. Editorial board member for Cochrane Fertility Gynecology, and senior editor Human Reproduction Open, and senior editor of European OBG.
We'll go on. Thanks, Fasi. Yeah, should be okay.
We are deeply honored to be there. And before handing over to you, I just want to introduce our chairperson. We'll start with Dr. Rendhir, immediate past chairperson MP ISAR, national accredited embryologist. A number of times we have heard Rendhir having presenting papers in the essay. There is a list of papers he has presented. And second,
thank you, Dr. Fesi. Thank you. Yeah.
Dr. Akhtar Bajaj, who is with more than 20 years experience in OBG and a fellowship with the fellowship in gynec oncology, head of Department of Obstetrics and Gynecology in the Ujala group of hospitals, and senior and that is his work experience. And thirdly, we have Professor Sheila Balakrishnan Madam, who was a former professor and HOD of the Reproductive Medicine Government College, Trivandrum. Started first IVF center in public center in South India, fellowship in reproductive medicine in UK, and author of 4 books of textbook for BG, which is most sought after books for undergraduates, and active faculty National International Conference, awarded PhD, and Rotary Best Doctor Award. Over to you, the chairpersons.
I think Dr. Kamath, you can start with your topic, and I think we all are waiting for you. So
Thank you.
Topic is PGT. Yeah.
I'll just share slide. Okay, my slide is visible. Thank you.
Yes.
Yeah.
So before that, Kamath, I have to introduce you, because just I'll take few seconds. He's at present he's one of the, I consider him the most person who is now a scholar and who is the Cochrane reviewer. So I think, and he's heading the journal of ISAR, and he has been in the academic. I think nobody can match him. So the PGT, I think again this topic you will do a justice, and we are free to ask the questions in future. Thank you.
Yes.
Welcome.
Thank you, Dr. Randit. Always a pleasure and happy to answer questions. I hope there'll be lots more after this. So, so this is a topic which is close to my heart, because I, not only as a clinician, but as a person who is into clinical research, I follow endometrial scratch and PGT evolution, the way it has been going on. So this is an update on where PGT stands. I don't have any commercial conflict of interest. I do have academic positions, but these are my own views and not a representative of any journals that I hold positions in. So introducing the topic, I'm more keen on all the youngsters here just to take you through the journey of PGT, how technology is actually introduced in clinical practice and how it, evolves. So it's a very interesting journey. And then, of course, the current evidence for PGT, and mainly I'll be discussing RCTs wherever it is possible. And I'll be discussing the current practice guidelines and my own thought process on where we are heading. See, for us who are in ART, this is nothing but a picture of white elephant. So if you really want to ruin somebody financially, then we present them a white elephant, So some of the ART technologies can turn out to be like that for units and, departments. We need to be very careful of what we are investing in, getting in. There should not be any hurry. It should be a very considered decision, looking at all pros and cons. And it takes a while to actually figure out if a technology is working or not, because we are trying our best for our patients. And it's not an easy thing to decipher. So the PGT, or we call it PGS at some point, it's a very straightforward logic. It was introduced in, I think, early 90s. And the idea was to select the most competent euploid embryo for transfer, which makes sense because most of the embryos don't implant because of aneuploidy. The target population naturally for this kind of reasoning would be advanced maternal age, RIF, RPL, one of the focus of this particular webinar, and severe male factors. We expect a slightly higher rate of aneuploidy. So these were the subset of patients where we thought it will benefit. So just look at those 4 subsets, and then we go on dissecting the technology. So this is PGS1, and the landmark paper came in early 90s, as I said. And this group went on, and of course, there is a clear rule for PGT when you have an identified genetic issues in one of the parents. So it makes sense, and the embryos, you need to screen them and so on. The problem was the extrapolation of this technology beyond the clearly indicated reasons. There was a flurry of activity, and there are a lot of people who started dabbling with cleavage stage biopsy and PGT with utilizing very early genetic platforms like FISH and karyotype and so on. Now, while it was introduced, it took a decade or slightly more, decade and a half, if I call it, in 2007, where Sebastian Mastenbroek and his team came up with a randomized trial. And you can see here that actually PGS at that point was associated with significantly lower live birth in women, especially advanced stage. The population where we should be targeting, it actually hurt them. We lost many patients who could not become pregnant. And that was a landmark paper published in NEGM, and that kind of put a break to this usage of this particular technology for some time. And then obviously we evolve. We as humans try to evolve and come up with better solutions, and this is a natural scientific discourse. So you had better platforms, CGH, and finally we had NGS, and we moved on from cleavage stage to blastocyst stage, tropoectoderm biopsy, and so on. There were some very controversial data that was coming out and systematic reviews getting published pro these particular platforms and technology. So if we are, very keenly trying to dissect these kind of systematic reviews, people can come out with a lot of issues with them. So this particular one published in PLOS One, they had published 2 RCTs, which did not surely show any effect, but you can see here the cohort study. So traditionally, if you are looking at a meta-analysis, cohort studies should actually be taken off, and you should try to read only the RCTs. But you can always see that cohort studies tend to overestimate the benefit. So you can see here a very good, they got the forest plot also not so correct. So there are a lot of issues, but then these kind of literature keep coming in, and people start thinking, okay, there's a systematic review which is getting, favoring PGT and so on. So adoption went on to the different level. But there was, evolution in the technology also. At that point, a lot of people were not considering putting the mosaic embryos back in because we didn't have information. Everybody was scared, babies will come out with anomalies and so on and so forth. So there was a clinic in US which figured out they were pushed to the wall, and the couples came all the way to them asking, we have only mosaic embryos, can you transfer? And they took all the particular regulatory permissions, and they went on putting the embryos with obviously the consent of the patients, and they figured out that the babies born were perfectly healthy. So what it tells us is that what we didn't know exactly what was happening with the mosaic embryos, but the end, if you actually go back and see, all those patients who were denied embryo transfer because of mosaic embryos had lost a chance to conceive because of incorrect information, I would call it, or lack of information. So this is the way we are evolving. We were learning on the course, but it's important to know how to learn. We can't run on routine practice. Then slowly we had a flurry of trials coming in. So this was the ESTEEM trial, which was on polar body biopsy. It's from Europe, and it had its own issues. But then because it didn't mimic exactly the current practice at that point, they had CCS, not an NGS platform, and they used polar body biopsy as far as I remember. Essentially, they found out there's no difference in live birth rate. Yes, you will require number of embryo transfers to be less. And it is quite plausible and understandable that the miscarriage rates will go down with PGT because you are screening out a majority of aneuploid embryos. This finding was not surprising, but bottom line is the live birth rates did not change after offering this technology. Then the famous STAR trial came. And this trial, see, if, it's very important not to get swayed by big names and big journal names. It is very important to understand that a lot of our trials, as I've understood, have huge methodological issues. And there's always, a lot of weak trials also get into good journals, and the caveats are missing. So this particular trial, if you go by the purist version, the trials, how they have to be analyzed, we normally go by something called ITT analysis. That is, every lady who has been randomized has to be accounted for in the final analysis. Simple, and that's the way to put it. So we found that there was no difference in pregnancy rates, ongoing pregnancy rates, whether you offer PGT or not, in people who had at least 2 blastocysts. Generally a good prognosis case. And they did not have any difference even in the advanced age group of 35 to 40. However, the results, the way it was done and highlighted, the post hoc analysis, which is always called an exploratory analysis. We are not relying on those findings. They are just the first step to launch different trials. This is not the main thing, and it is afterthought. We got the results and now we need to figure out how to present it. So there can be, a lot of issues in this kind of analysis, but that was projected. And in fact, it was projected in the conclusion and abstract also. That's why, we need to be very careful. So post hoc analysis, they tried to show that there was a per embryo transfer increase in PGT, again, which is not a entirely convincing argument, because per embryo transfer PGT is likely to do better, and that is something that is done a surprising finding. This was also having a commercial interest, and I think the pressure was too much to prove that this is working, and it is understandable. So there were people who were watching all this, and they were very vociferous in voicing out all the issues, which is very good. In a scientific discourse, we need to have both sides of the coin. So there was a group which constantly they came up with opinion papers and rebuttals and so on, and it's a good thing to learn. So this was a classic point where RCTs, you have to have the denominator as per woman randomized. They pointed this out. Intention to treat should be the standard of analysis and not embryo transfer. Now, we move on, and then people said, yes, we can't prove that live birth is increasing. Cumulative live birth is not going to increase with PGT. Let's change the focus. Our patients want a less time to pregnancy. So new goalpost was set up, and you can see that a lot of focus is there. Yes, I agree that time to pregnancy is an important matter for our patients, but how much time, 15 days, 1 month, is not really a time that patient matter. They are looking at cutting down from years to months, if not anything else. But let's say time to pregnancy can come down. But my argument for this is it's a flawed argument, because whenever you're launching an RCT, the control should mimic the standard of care. And what is my standard of care in real practice? Real practice would be somebody could get a day 3 fresh transfer, somebody get a day 5 fresh transfer, or I might choose to freeze on day 3 or a day 5. I cannot be straitjacketed in a control to only a day 5 frozen just to make it equivalent to a PGT, which requires the freezing of day 5. So this kind of methodological manipulation done can give you very erroneous conclusions, So that's where I think we need to be very careful. If people start projecting time to pregnancy is lower in PGT, then it's not a entirely scientifically, you can't really fight it out. There is a flawed argument, I would say. Not surprisingly, Cochrane can't, come up with something very different, because the trials are not going to show anything. But one thing which I had heard long back from Sebastian Mastenbroek, PGT will never improve the cumulative live birth. And that is what exactly the evidence will show. It is insufficient good quality evidence to show a difference in cumulative live birth. That's the bottom line that we need to understand. It may get you there earlier with less embryo transfers, but we need to focus on what are we losing in the bargain. Trying to reduce the time to pregnancy, what all are we losing? Then came one of another landmark trials, which was from China. And this had 1,200 participants, which was a non-inferiority trial. What it considered was that PGT was considered a standard here, and conventional morphology, that is the normal way we do it, was considered it may do not as well as PGT. So it will be a non-inferiority trial. It's a change in terms and the way it is planned. They said that even if conventional one does between 8% as good as PGT, that is lower than PGT, then also we are fine with it. That's the argument for a non-inferiority trial. They included people who had at least 3 or more blastocysts. And you can see the results there. Cumulative live birth in conventional arm was 82%, close to 82%, whereas PGT, it had gone down. This was a very satisfying results for me personally, because I was looking for this kind of evidence I may be selective, but then I was thinking that where is the loss that is getting caused because of PGT? And this trial captures that 5% loss of live birth. And why it captures, you can go through the discussion. Possible damage due to embryo biopsy. See, also remember that some of the data that comes is from high-end IVF units which are doing PGT day in and day out. There are a lot of units which might not be able to match up to these people in terms of culture conditions and PGT skills. And that will lead to further loss. And there's a huge issues about false positive and negatives. And then the argument was that the TE biopsy might not be actually representative of the inner cell mass. So there were a lot of issues, but to me, the top one was the damage caused to the embryos because they might be hatching at the time of freezing and so on. So there were so many technical things that my embryologist felt would point out. And that would have led to this 5% loss in live birth, cumulative live birth. But anyways, that's where the evidence stands. And these two big trials actually shape up the current guidelines. And thankfully, the guidelines have been fair and neutral because it's very easy to influence some of these guidelines just by matter of one trial, but they have been very, very neutral. They have left open the door for more research and pointed out how the research has to be done. So overall, there is no benefit of PGTA. Most studies actually included good prognosis. If you go back to my first slide, which clearly indicated the subset of patients where it should be targeted, all the trials stayed away from it, and for a reason. The reason was that you will never get that kind of a blastocyst in an advanced maternal age for PGTA. You know, it's not an easy thing. A lot of patients will be lost in the bargain because they might not reach that stage. Then, of course, they have clearly indicated randomization should be done at the start of the IVF cycle, not at the time when the embryo transfer or blastocysts have come. That's an erroneous way of doing it because a lot of patients will be lost by the time they reach the randomization. They are not counted in the calculation. That's not the right methodological way. And finally, the recommendation was clear. Routine ones cannot be recommended. They were quite firm. These are updates. HECA traffic light also says the same. There's a big red for PGTA. Yes, there's a green for reducing miscarriage, which is understandable. If you want to reduce miscarriage, there is a case for individualizing, and we can offer that. Clinical add-ons, non-invasive PGTA. Already people have moved on to non-invasive. So I see a lot of patients coming to us in CMC getting the non-PGTA reports wrong. It is clearly mentioned in the guidelines that it's in research phase, but clinical practice, it is already being offered, which is a big concern. And it brings me to the bigger question that we kind of lost that line between research and clinical practice. That routine word is not working anymore. So this is just one slide I've added because I took this from the ISAR and practice guidelines, which mentioned the use of PGTA and RPL. I was interested in seeing if there are any RCTs on this topic, but there were no RCTs, and it's difficult to offer RCTs. This is a SART data from the US, and it's restricted to those women who are going FET for maybe secondary infertility, but had RPL. Okay, it is not standalone RPL. It was only restricted to those couples who were going through frozen embryo transfer with a history of RPL. And database studies have their own issues. It showed significant improvement PGTA following live birth following PGTA, especially after 40s. But surprisingly for the authors, there was no difference in miscarriage rates, especially after adjusting for the confounders. Overall, this data was used, but the ISRM practice committee clearly said that PGTA has till date not shown any benefit in RPL. If we are looking at RPL, I actually am very skeptical of offering IVF in patients with RPL because the patient will undergo double trauma. Even if they conceive, they end up having miscarriage, which can be quite traumatic. This is the ESHRE guideline on RIF, and people do use PGTA in RIF, and it shows can be considered. But again, the data, we also remember RIF itself is a very problematic diagnosis. Your RIF and my RIF would be very different. So I'm quite skeptical because the definition is not operational. There's just huge heterogeneity. And ESHRE recommendation did not come based on an RCT. They came on 2 cohort studies. And I have shown you that cohort studies tend to overestimate the effect. That is, overestimate the benefit. We should not get carried on with this. I like to follow this particular group, Norbert Gleicher, and they have a lot on plate when it comes to PGTA. And this is a very good article, which is actually opinion paper on how not to introduce a lab test into clinical practice. And they clearly go through the history of PGTA. And one of the very important thing they have highlighted is what has happened is for PGTA, the proponents have shifted the responsibility of proving it to the opponents. So it's the opponents who have to sit and sort out and tell and prove or disprove PGTA instead of the people who got it, which is opposite of what a scientific discourse should be. If I had to prove something, I have brought something new, I need to prove it beyond doubt. And that's not happening. And other thing, North America, PGTA is offered right and left for a reason. It's because of the insurance, which restricts the number of embryo transfer. So don't start extrapolating what's happening in US to this part of the world. Our patients have limited financial, muscle, what do you call it, limited resources, and they pay from their own pocket. And we need to be cognizant of this. Of course, PGTA, cell-free DNA concordance rates haven't been very remarkable, 85, but my problem is what's the reference test for this is always a concern. To me, finally, I would just sum up that be very careful. As I said, the line between experimental and routine clinical practice seems to have disappeared. People are offering what is to be experimental as a routine practice. Why and what is a thing we can have a debate on. I always feel for all the people and the couples who lost their opportunity to conceive because of the way these technologies have been introduced. And there's I think this is all going to come back to us, and I'll show you why. Remember one thing, cumulative live birth is not going to be improved by PGTA. It will never improve the implantation potential of an individual embryo. All it can do is shrink the denominator of embryo transfers. And once we commit for PGTA, we need to commit for a blastocyst culture. We need to commit for a freeze-all. We need to commit for a no ET or a cancellation. And we need to commit for a higher cost for so-called increase in E per ET success, and possibly a lower cumulative live birth. That's the cost that all of us should be actually discussing with our patients before offering this technology. So this is my favorite slide, and I like to give this, opposite sides of evidence and what the power of knowledge can do. So this is what I love, the forest plot, where there's a lot of information, 1950 to 1980, 87, where we had some information, but we didn't know how to decipher the information. So this was about use of streptokinase in MI, and so many trials, everybody started doing right and left in their own world and clinics. And even in 1987, we didn't know whether streptokinase was actually saving lives in MI. But if people learned the art of meta-analysis, the science of meta-analysis, in 1975 itself, with all the trials, we had the answer that streptokinase actually was saving lives. Okay, this is the power of scientific knowledge and how we actually should be doing clinical research. So meta-analysis actually would have proven at least a decade before that we could save lives. But that was a case of too late. And we are in an era where we are just too early. We just want to introduce technology because we want to do something for our patients. It's a very natural thing. But remember that there is a cost and we need to look at that. And if people want to know more, there is a lot more on where it is going. There's a big cases and legal cases have come up now because exactly the reason, that is, many embryos were discarded because we didn't think they were fit enough. So my final slide is PGTA. Most RCTs have come from good prognosis group. 1, 2, 3 is all over. Now we are moving on to 4 PGTA. Unfortunately, there are no RCTs for the group that you and me are most keenly following, RPL and RIF. They are the most difficult, patients that we face. We want to really help them, but PGTA does not have an answer for that. Remember that technology comes at a huge cost for our patients, and we need validation beyond doubt. There is an ethical angle, but if that's not enough, there is a legal angle. And I think we all are responsible citizens. Doctors are supposed to be doing that. Be responsible for the new generation. I close my talk here. Thank you.
Thank you, Dr. Mohan. It was a very, very interesting and knowledge. And I think you have answered many questions. And with the history that initially the mosaic embryos were discarded, but when there was no choice, they took and that. And the part in the USA and the other countries, because they are insured, and in India also now the new RT Act has come that you have to transfer. They have limited that you have to transfer 1 or 2 embryos, maximum 3. So I think this platform is open. I'll request other chairpersons to ask the questions.
Dr. Mohan.
Yes, ma'am.
Yeah, excellent presentation as usual. Very, I mean, we think alike. I liked it very much.
Thank
I
you.
really liked, yeah, that classic example of a diagnostic test introduced prematurely. I think so many tests, ERA is another one. It just came, it was just meant for one lab. They just introduced it, and now it's an end of an era. Same thing, so many things. And we are seeing the same thing everywhere because everything has been introduced without, I really feel like that. I would like to ask you about, yes, in RPL, I do agree. And in RPL, you mentioned the trial, but then in RPL also actually is, if at all it's indicated, it's only in those with translocate. And then you have to do PGT-SR, isn't it?
Yeah.
PGT-A, would there be a role? I'm not sure.
No, that's what,
If you're
ma'am.
doing PGT-SR, fine, you could do an A along with, that's all, isn't it?
Yeah. Otherwise, PGTA generally, I would be skeptical. But only thing is, people, if they are looking at IVF because of infertility and they have a history of RPL, then people tend to, offer this. And you can make a case for reduced miscarriage rate. But if we say that that it should be, it's going to increase the live birth rate, that's an erroneous thing.
Yeah.
That's all.
Yeah, and the older women also. The women who really need it, it's very difficult to use it, isn't it? We find so.
I think, ma'am, we'll end up with no embryos also.
Absolutely.
And that's also, we don't know how it will pan out. We need to
And
really
the harm.
tell them.
We really don't know how much would you say? The 5%, I think much more than 5%, isn't it?
That's what, ma'am. One of the things is some very good labs might do, people, it's a skill, it's not like everybody can do. And what stage you are doing the biopsy and so on. There's so many technicalities there, which is lost. And even in the trials, what has been shown across the units, there's a huge variation in euploidy rates. So that's where it is. So even blastocyst culture will not improve cumulative live birth. It can only increase per embryo transfer. So committing to blastocyst so will probably, we might lose out if we try forcing system like that.
Just one last question about, you mentioned about the positive. I mean, what about the reverse, the false negatives? Have we any this thing on that? It's difficult to.
Yeah,
we always say that even if you do PGTA, you have to do, I mean, if you're sure, you need to do first trimester screening or amnio, whatever.
Yeah, I think that is something that I've not really looked into because I don't offer. But most of them, people do offer it and all. But that is something that we will not. Yeah.
Thank you anyway. Very nice, Mohan.
Thank you.
Dr. Akta Bajaj, do you have anything?
Thank you, Dr. Kamath, for a wonderful talk. It was very insightful. Thank you so much.
Thank you.
We have one question, chairpersons.
Yeah, there's one question. Just a minute.
Drawback on NI.
What are the drawbacks of NIPGT?
Yeah, the drawback is that we don't know what we are analyzing. We need to prove concordance. There is and what is a reference test? So I don't consider PGTA as the standard one as a reference test. I always ask people, what is your reference and for PGTA itself? People have to tell me, and it's a very difficult question. People haven't thought through. That's why I said these are diagnostic tests. They can't be assessed as an interventional strategy. And I want to hear from the lab people, and how do you prove an index test like this? So people don't give me answers, they confuse me in jugglery, that's so NI non-invasive PGTA, you need to prove it. A concordance rate of 70% with a PGTA itself is not good enough. And also we still are a long way. What I understand is there can be so many issues and there could be contamination and everything else. So it is still experimental. I will leave it to experts to come out with clear validation, and then we can move it on.
No other questions, I think.
Thank you, Mohan, and the
Thanks.
chairpersons for that very which eye-opening because into the facts of this PGT. Thank you, Mohan.
Thanks. Bye. Thanks.
Thank you. Bye. Good night.
Next, we have the second talk today, role of POC testing in case of recurrent pregnancy loss. Our speaker is Dr. Fiona D'Souza. Before introducing the chairperson.
Thank you, Tessie. Yeah.
Let us see the CV of Dr. Fiona. She is the head scientific operations, clinical genesis Anderson Diagnostic Services Private Limited, and heading genetic operations of India, Sri Lanka, and Nepal at Anderson, and her program lead of education academic partnership and scientific academic contribution to over 13 publications in high impact factor journals, invited faculty at national and international conference, member of IFS special interest group on applied genetics, and areas of specialization is reproductive genomics, prenatal genetic diagnosis and preventive genetics, molecular mechanism in early embryo development. And we have got excellent chairpersons. First chairperson is Dr. Monica Singh. She doesn't need any introduction. Consultant Reproductive Medicine, Bhopal Fertility Endoscopic Center, Professor of LN Medical College, Bhopal, Managing Committee member of ISAR, Vice President Bhopal OBG Society, Bhopal Menopause Society, Honorable Secretary member, Chapter of ISAR, West Zone Coordinator Medical Disorders Committee of FOXY, past Coordinator of FOXY Infertility Committee, Sexual Medical Committee, Organized Secretary of ISAR Conference in Bhopal 2023, and she had won lot of awards and achievements. And next we have Dr. Seema Sharma, Senior Consultant Cloud9 in Vikaspuri, Founder Director of Indian Recurrent Pregnancy Loss Foundation, co-founder of Pradishandi Foundation, special interest in RPL and sexual medicine, authored 4 books and regular on Josh Talks TV and radios. And also we have next chairperson is Yashika Gudeshwar. I don't know whether I have pronounced correctly or not. Unique Director of Max Dwaraga, and she is a present Secretary of DGF Southwest and life member of IOGD, FOXY, IFS, IMA, and faculty of Ethicon. And she is specialized in painless delivery laparoscopy, ultrasound, medical legal systems, infertility, and won awards is Dwaraga Doctors Forum Award, Hall of Fame by ET Health World, DGF Abdul Kalam Award in 2022. And she has got work experience of ex-HOD of Manipal Hospital, Dwarga, worked at St. Stephen Hospital and Deen Dayal Hospital, Mada Chanan Devi Hospital, Bhagat Chandra Hospitals, and Fortis Vasant Kunj with experience of more than 20 years. And special interest in adults in care, PCOD, painless labor, laparoscopy, and postmenopausal care, gynec, cosmetology, and high-risk obstetrics. Over to you, chairpersons.
Thank you, Dr. Fessy Lewis, for introducing you. Since you have already introduced the speaker, Fiona D'Souza, who is going to speak on the role of POC testing in cases of RPL. So we begin this topic 2 of the talk with now a little doubt in our heads, because categorically Professor Mohan Kamath has said that PGT does not improve the cumulative live birth rate in ART pregnancies, and it comes with a lot of cost. So I have that same reservation for POC testing. RPL, the causes are so varied and there is such a lot to investigate and counsel the patient that once the products are out, whether to be tested or not, will totally depend upon how the speaker takes the topic and gives a clear take-home message. So the stage is all yours, Fiona, and we are eager to listen to you.
Very good evening to everyone. Today, my topic is the role of POC testing in cases of RPL. I would like to declare that I'm a full-time employee of Anderson Diagnostics and I have no other conflicting interests in my presentation. So recurrent pregnancy loss, as we all know, is defined as when a woman has had 2 or more pregnancy losses or miscarriages before 20 weeks of gestation, and the loss has to if a clinical pregnancy loss has to be diagnosed by an ultrasound. Now, the etiology of RPL is extremely diverse. There are multiple causes, and they cannot always be pinned down to genetic causes alone. So, to name a few, we have parental chromosomal abnormalities and aneuploidies in the fetus per se. We also have anatomical defects, infections, autoimmune issues, hormone fluctuations, epigenetic alterations for which we do not have any diagnostic testing at the moment, and you also have male factor and thrombophilia. So when you look at specifically the chromosomal causes, if you look at natural pregnancies, 50 to 60% of natural eliminations are chromosomal in nature. So genetic testing in the product of conceptions helps us to identify a potential genetic cause of chromosomal anomalies in the fetus. This kind further directs informed decision making for next pregnancy management for both for the clinician as well as the patients. And in case there is a hereditary risk factor to these anomalies, then for the clinical management will possibly change. So if you look at the chromosomal causes, you have multiple types of chromosomal causes. They could be numerical in nature. We call them aneuploidies when there is a single chromosome change. We also have polyploidies when all chromosomes are in an additional number like triploidy or tetraploidy. We can also have structural rearrangements like translocations and inversions causing deletions and duplications in the fetuses. We also have single gene mutations, and also some cases we have polymorphic segments which can predispose to RPL. Now, if you look at the chromosomal causes distribution, of course, the most common chromosomal cause is trisomy 21, followed by trisomy 13 and 18, and of course, monosomy X, which is Turner syndrome. And then we have 16% of rare other chromosome anomalies. And it is a well-established fact that the incidence of spontaneous miscarriages and the risk for aneuploidies significantly increase as the patient crosses the age group of 35. Now, when it comes to genetic testing in the product of conception, a very strong statement was released by American College of Obs-Gynae as well as the Society of Maternal Fetal Medicine, saying that the chromosomal microarray is the test of choice for pregnancy losses. And most of the genetic testing identified by the chromosomal microarray are very small compared to the standard karyotyping. So karyotyping is now almost redundant in the product of conception samples. And therefore, even the deletions and duplications not associated with maternal age can also be picked up by the microarray. Chromosomal microarray is also recommended in fetuses that are structurally normal or for the evaluation of intrauterine fetal death or stillbirth. Here, I would like to also put a comment that the probability of a chromosomal cause with the structurally normal fetus or with IUD is always a little more on the lesser side. The diagnostic is much lesser for these two categories. But for the first trimester pregnancy losses, the chromosomal microarray works extremely efficient. We also have the advantage of including maternal cell contamination check into the genetic testing when we offer POC testing. This will help us decrease false negative results. And a comprehensive pre-test and a post-test genetic counseling should always be offered to the patient while giving them an option like chromosomal microarray, because we need to explain to them there is a possibility of no results to be generated, and there is also a possibility of things being normal. Now, a quick word about the sampling, because this is a challenging case in first trimester losses. Ideally, what is preferred is the fetal tissue. And even if the sample is transferred to formalin or formaldehyde, even for 5 to 10 minutes, it can significantly alter the quality of the sample that is available for testing. And a sensitive test like microarray cannot be performed with compromised DNA integrity. Now, usually a maternal blood should be always accompanying the fetal sample. In case you are providing the placental tissue, usually placenta is not tested for chromosomal microarray. What the lab actually does is we dissect it under a microscope and we take out only chorionic villi for the testing, and then the testing is performed. That is because chorionic villi will be representative of the fetus and the placenta will not. Now, the microarray can pick up trisomies, monosomies, deletions, duplications, and triploidies, and these are the main purposes for offering the microarray. So I will take you through a series of cases that we had, and then raise a discussion on these cases. So this was a woman who was 29 years old. The partner was 31 years old. They were non-consanguous. They had 3 natural pregnancies with no cardiac activity. And the 4th pregnancy was actually an IUI because they also had infertility after that. They weren't able to conceive naturally for a year. And this last pregnancy did come up for the genetic testing. Now, when this was offered, we were able to get trisomy 14 in the product of conception sample. Now, what is important to understand is trisomies are usually meiotic in nature. They are de novo. They might occur from the egg or the sperm. And parental karyotyping usually comes out to be normal, as would be the experience of many people who offer the genetic testing in product of conception. So when the karyotyping is normal for the couple, the recurrence risk of the genetic disorder reduces significantly. Now, we should also remember that while offering these tests, it doesn't mean that the presence of one condition rules out the possibility of other conditions. So we do not have strong evidence about the genetic cause in the previous 3 pregnancies. There could be non-genetic causes. So most people in this situation, now that a genetic cause has been picked up, would offer a PGTA in the IVF cycle and an IVF cycle. Now, if this patient was naturally conceiving, an IVF cycle is not indicated just based on the trisomy 14 because we want to offer PGTA. As you have clearly understood from the previous talk, these kind of findings do not really warrant the application of PGTA. But if this is an IVF going patient, PGTA can be offered with proper counseling, because when the karyotyping of the patient is normal, the recurrence risk of a trisomy is age dependent. So if you factor in that the female partner is 29 years old without any chromosomal anomalies on the karyotype, the possibility of recurrence is extremely low. And this is why generally other causes of recurrent pregnancy loss needs to be ruled out in this patient before offering an expensive intervention like PGTA. This was another case where we had a non-consanguous couple who went for a product of conception testing at 7 weeks. Now, usually 7 weeks is kind of an arbitrary cutoff, because any gestation before 7 weeks, the fetus is too small, and most of the time we get no fetal DNA. At 7 weeks, we are able to get a fair amount of samples which will give us results. And we found a case of triploidy. This means all the chromosomes are in 3 copies. Now, triploidy is a one-off event. It does not recur frequently. And if it is a triploidy, additional testing of the parents is not indicated. And we can generally counsel the patient that the possibility of this recurring is extremely low, and therefore no interventions are planned, and the patient is planned for a fresh pregnancy without any clinical intervention. So this is what basically a triploidy looks like. This could be both maternal or paternal. It can be because of retention of second polar body inside the oocyte, or it could be caused by multispermic fertilization in utero as well as with IVF pregnancies. Now, the most important causes for RPL, recurrent RPL in the first trimester, is balanced translocation. Here, it is defined as when a patient is carrier of a balanced translocation. That means a part of the chromosome detaches from the parent chromosome and relocates on another chromosome. This individual will be completely healthy, but faces significant challenges in reproduction. So about 50% of the gametes produced by these patients will have unbalanced products, and these patients will suffer recurrent miscarriages. Parental karyotyping is the only way. However, if you offer product of conception testing, unbalanced products can easily be picked up by the microarray. Likewise, you also have congenital disabilities and mental retardation also associated with these findings, provided it depends when the testing has been performed. So a little bit information on how these reproductive outcomes change with translocation carriers. It is always understood that when a male partner is a carrier of the translocation, the outcome is always better compared to the female partners, because in female partners we have fewer number of oocytes, and we also have maternal age to account for. So the study by Verdone et al. Very clearly showed that the possibility of aneuploidy is always higher when the female partner is a carrier of a Robertsonian translocation. So there is a risk of 31% for recurrent miscarriages. You have about 5 to 18% possibility of an affected pregnancy or affected child. And because sometimes if the translocation is small, the phenotype might be subtle, and you may not always be able to see an anomaly during the pregnancy. You also have 33% of a possibility of balanced offspring, and 7% of people can also suffer from infertility based on the location of the translocation. So this was a case where a female partner, 26 years old, and male partner, 35, non-consanguineous couple, were undergoing recurrent miscarriages. We tested the third pregnancy loss, and this is how a typical microarray result expresses itself. There will be a loss on one chromosome and a gain on the other. And parental karyotyping clearly identified a translocation between chromosome 11 and chromosome 14 in the male partner. So in such cases, pre-implantation genetic testing for by PGT-SR is always recommended. Another case here I would like to highlight is this was a 31-year-old primary couple with primary infertility. Married life was 3 years, and they were an IVF couple. So when it is an ART pregnancy, even if it is a first pregnancy loss, it is always indicated to go for testing because this can shed light on a lot of other information. So this was an 11 weeks gestation with generalized edema, single umbilical artery, and omphalocele. These are chromosomal causes, phenotypes associated with chromosomal problems. Fetus was tested for microarray, and we clearly found a gain on chromosome 3 and a loss on chromosome 7. Now, this patient, of course, is an IVF patient. They had embryos frozen. So next step will always be PGT-SR. Another advantage of the microarray for especially couples who are going for PGT-SR is the microarray will clearly define the size of the deletion duplications, and it helps us understand the coverage of the PGT-SR for this particular case. So when we offered the balance karyotyping for the couple, we were able to pick up a balanced transcription between chromosome 3 and 7. And then this couple was offered for the following options. So during the post-test counseling, it is explained that there is a possibility of 30 to 60% of unbalanced resulting in a pregnancy loss. ART pregnancy with PGT-SR was offered. There are certain points you need to consider while offering PGT-SR to couples. First is a coverage. Most PGT-SR platforms will have a coverage size limitation to from 10 MB to 5 down to 5 MB. And this particular patient, if I can go back, you have a size loss of 3.5 MB, which is very, very small. So it was very important. This information was important while counseling the patient that the loss of 3.5 MB would not be covered with the PGT-SR option. There is a possibility of having balanced translocation carriers which the PGT-SR cannot pick. And there is a higher probability of all embryos turn out to be aneuploid, and we may not have any embryos available for transfer. So all this information was delivered to the patient, and then they were given the option to choose donor sperm for the next pregnancy. Just to quickly rehearse the PGT protocol, we would of course do a day 5 biopsy, and this is just a 6 to 8 cell biopsy. But when you deal with PGT-SR, since this is a translocation, the variation that we see in the embryos will be uniform and highly reproducible. Therefore, PGT-SR is a strong test to be offered for patients who are carriers of balanced translocation. So this is basically how the report looks like. This was a patient with a balanced chromosome translocation between 7 and 8. So for an example, I wanted to show that out of 5 embryos, though the risk is about 30 to 60%, we were able to find only 1 embryo available for transfer. And in most cases, we do not get embryos available for transfer in PGT-SR cases, resulting in more than 1 cycle. And the patient needs to know this information before considering such expensive. Another input is the polymorphic segments that are often seen on the karyotypes. It is important to understand that these polymorphic segments are generally present in the healthy population as well, who are able to conceive naturally. Now, they are associated with recurrent pregnancy loss mainly because the general healthy population will not go for a karyotyping. Only the RPL patients go for a karyotyping. And if you offer interventions like PGTA, the PGTA cannot visualize these polymorphic segments. However, there is some minimal amount of evidence suggesting that these kind of polymorphic segments can disturb the segregation of chromosomes and trigger aneuploidies. But it is important that you cannot pinpoint the entire pregnancy loss on these polymorphic segments alone, because there is very low amount of evidence for it. Therefore, because this is a normally present in the healthy population, we need to consider other causes of recurrent pregnancy loss and not pinpoint only these particular findings. These are normal benign findings. This is another case that I wanted to discuss. fetus. So chromosomal microarray is not the one and only test we need to offer. We need to look at the anomalies and then decide how to evaluate the pregnancy. This should be more carefully seen, especially in second trimester anomaly. So this was a pregnancy that was terminated at 22 weeks, indicative of microcephaly, agedness of corpus callosum, sloping frontal bone, depressed nasal bridge, and small membranous BF. So the microarray was initially ordered and it came out to be normal. What is important is, in especially cases with phenotypes like microcephaly, you need to go for further evaluation to see if there are mutations involved. And mutations are not covered in chromosomal microarray. So the whole exome sequencing in this fetus picked up a homozygous mutation on STIL gene, and this was also a consanguous couple. So the recurrence risk of this mutation, which is likely pathogenic, is extremely high. So the parental testing has to be offered in such cases. And while offering parental testing, we have two options. Either we can go to a conservative approach where we do a targeted testing for this particular variant, focusing on this variant alone. But since the couple is also consanguous, it is important that we rule out any other possible risk, because consanguinity increases the probability of having common mutations by at least twofold. Now, another case, the main indication while you choose a test like whole exome sequencing is phenotype. Now, if you do not provide the phenotype to the genetics company, they will not be able to give you an informative whole exome sequencing. That is why if a primary company does a whole exome sequencing with a particular type of phenotype, and then you give additional phenotype, the same company or a different company might give you a different report. So the whole exome sequencing, though the sequence does not change, the interpretation of the report is significantly based on the phenotype that is provided. And the second indication for whole exome sequencing is recurrent phenotype. Any kind of recurrent phenotype across more than one pregnancy, across at least two pregnancies, is indicative of a possible mutations that is underlying. So this was a very interesting case where the patient had two pregnancies, and in both pregnancies, we had significant elevation of nuchal translocacy. That is 4.6 mm in one pregnancy, another pregnancy it was 3.2. And third pregnancy was a miscarriage at 7 weeks. And the fourth pregnancy again had heteros fetalis with generalized edema. Now, because the edema also was significant, you will obviously get a higher nuchal translocacy measurement. And that is why the third pregnancy was tested by whole exome sequencing. So in the whole exome sequencing, we found two mutations sitting on the LZTR1 gene. Now, this pregnancy also went through the microarray, which was normal, and then it went to the whole exome sequencing, because this kind of finding is associated with both chromosomal causes and mutations. So after the array was normal, the whole exome sequencing was ordered, and we were able to pick up an autosomal recessive version of the Noonan syndrome. And it is important to see that since this couple was non-consanguous, we had two different mutations on the same gene, causing what we call a compound heterozygous condition. Therefore, this patient now has a significant risk of recurrence, which is now 25% because of the autosomal recessive nature. And therefore, then they were offered option of either PGTM or a donor. There are other causes of variants that are not present in the fetus. This would be mainly genetic thrombophilia. However, the amount of evidence vouching for genetic thrombophilia predisposing patients to the risk of RPN is low and debatable. Therefore, it is not strongly recommended for testing in RPN cases. However, the most common variants involved are certain polymorphisms on the MTFHR gene, factor 5, factor 2, and PI1 and ApoE gene. Now, it is important to notice that when you do this kind of testing in parents for what we call polymorphism, they are not strongly correlating to the condition. Therefore, you cannot offer these mutation testing in embryos. So basically, these are just for explanatory purposes. So generally, this is why these tests are not indicated. Now, when you have phenotypes, especially when you deal with hydatiform molar pregnancies, you need to realize that there are genetic conditions at the background of molar pregnancies, and especially hydatiform moles are associated with autosomal recessive pathogenic variants on several genes. Most common of them are NLRP7 and KHDC3L. So these usually we dismiss molar pregnancies to be chromosomal in nature. Their recurrence risk is extremely low. But if you see recurrent hydatiform moles especially, then genetic testing in the parents is recommended. This was a similar case where we had a non-consanguineous endogamously married couple, and they had 3 pregnancies back to back with hydrotephomone. And then we went in for testing for the couple, and we found that the male partner was a carrier of a mutation on NLRP7, and the female partner also had the same mutation, and she was also homozygous for that matter. Therefore, most of their embryos would inherit both mutations, and therefore, these patients were not even eligible PGT-M or a self cycle in IVF, because this kind of mutation on this particular gene affects the developmental ability of embryos, and therefore they were offered a donor program, because the donor egg program is the only way this couple was able to conceive. You need to realize that while offering this variety of tests, genetics lab apply a variety of platforms, and therefore a single test cannot cover all. Every test has its own limitations, and a quick review about these tests and what they offer. Now, karyotyping is a gold standard test. It may not be offered for POC samples, but it is a gold standard test to pick up translocations. None of the other advanced molecular tests like the microarray can pick up balanced translocations. And therefore, in RPL, karyotyping of the couple is absolutely mandatory, and we cannot forego it for any. The role of microarray for the couple in recurrent pregnancy loss is minimal. The findings do not correlate with any significant association with RPL. Microarray is absolutely meant only for the POC samples. And if a genetic disorder is already known, a targeted testing can be employed. If we are looking at common conditions like neonatal deaths, deafness, imbalances of metabolism, dwarfism, we can employ a small the whole exome looks at the entire panel of genes, and this test should be carefully given with phenotype, because there is a possibility of finding variants of unknown significance and their interpretation is limited. And if all the mother as well as the children are affected, then mitochondrial genome is indicated. So it is quite important that while you look at whole exome sequencing, most of the reports will have BOS, and right now current clinical guidelines do not advocate interventions for BOS variants. Without any clinical correlation of the variants, we cannot plan any kind of termination of pregnancies or donor cycles based on this. Therefore, we usually don't intervene for BOS variants. We plan interventions for pathogenic and likely pathogenic variants. So to conclude, genetic investigations in the product of samples are extremely informative when you're trying to explain to the patient the cause. But if there's a translocation, definitely there's a recurrence risk, and this sheds light, and it is important enough to perform these testing. But affordability is a significant factor in our country, and in case the patient is not affordable or not in a mindset to discuss the genetic testing on the day of the termination, POC DNA banking is a viable option offered by all genetic companies in the country, and we can go back to the sample at a later point of time, counsel the patient, help them understand the risk versus benefits of testing, why are we performing this test, and then they can make an informed decision to test or not to test. The chromosomal microarray, of course, is highly informative in product of conception samples, but if it comes negative and there's a significant phenotype present, it should be followed by additional testing with whole exome sequencing, and this can help us plan future pregnancies in a better way. In cases of intrauterine demise, where there is no abnormal phenotype detected in the fetus, primary investigations will include the fetal autopsy and the placental study as opposed to the genetic test. Alternately, we can also store a skin tissue biopsy of the fetus. In case the fetal autopsy gives us any kind of phenotype associated with genetic disorders, by discussion with the pathologist, we will come to know about that. And based on that, genetic test can be ordered. This way, we are ordering the genetic test in an informed decision way, and not overall without having any kind of phenotype.
Wonderful, Chair, Dr. Fiona. Over to you, chairpersons.
Well, I think it was fantastic, Dr. Fiona. So I had one question. How common, as you rightly pointed out, that microarray is now the test of choice in POC. Do you also have conditions where we can offer microarray with karyotype for POCs? Because you just mentioned that with karyotype, the problem is like culture failures and all are very common. So, we want to do a microarray. Microarray is expensive, I recently had a case where the microarray came negative because they said there is a maternal cell contamination.
Yes.
So how often do you find that, and can we order these two tests together in some conditions?
So primarily, the karyotyping has been discontinued in POC samples because for karyotyping we need live tissue and the POC sample is a dead tissue. Because it is necrotic, we get contamination and there would be no point in ordering the test. But for the DNA-based testing, we do not need a live tissue. We need tissue that belongs to the fetus. When we do the microarray, there is always a significant risk of no fetal genotype, especially in pregnancy of 6 to 7, 8 weeks. About 50% of our pregnancies of the 7 weeks GA will have no fetal genotype. So this is something we offer to the patients and we tell them, let's take the sample and do the MCC first, do the maternal cell contamination check, and then we bill the patient for the microarray because unnecessarily they end up paying for the microarray and then most companies end up not refunding and the patient is extremely disappointed. So the pre-test counseling before offering a microarray is extremely important. The incidence of finding abnormalities in the microarray is similar in both IVF and naturally occurring pregnancies because we evaluated our data. We found that 60%, as per literature, we correlate that 60% of the array findings are abnormal, and doesn't make a difference if it is a natural pregnancy or a IVF pregnancy. But in IVF pregnancies, it becomes more important because patients go through so much while going through IVF. So if they need a reason why this is miscarrying. Also, the importance of the microarray test, ma'am, is that if we find a chromosomal cause, we need not put the patient on prophylactic treatments like aspirin, low molecular weight heparin, or go through those lab tests for immunological profiles which are going on now. So we know it's chromosomal, so we can assure the patient the recurrence risk is extremely low if the karyotype of the couple is normal. So this makes the clinical management much more easier, especially for the patients.
Yep. So we have started doing POC testing in almost all our recurrent pregnancy loss cases. And we have also started offering DNA preservation for even one abortions. This is just an offer because it's like cheap, $1,500 for a DNA. So people who are high risk, elderly and all, we have definitely been offering them DNA preservation from even the first abortus in case they want to.
Yes, ma'am. That's extremely a very good way to do things because if we have say 3 pregnancy losses and we have DNA stored and we have only the 3rd pregnancy loss,
Go back and test.
Can go back and at least correlate, what has happened. And because just because we have found a pregnancy loss, one of the pregnancy loss to be chromosomal doesn't mean the previous 2 are also chromosomal. So that is something many people forego. We find a positive result written in red and we focus only on that. So that may not be always informative for all the time.
So that is the
good.
I wanted to ask you, Dr. Fiona, that why in an index case, one of your cases was an index case wherein the patient had gone for POC testing. It turned out to be, I think, trisomy or something,
Yes.
which is like the patient had a normal pregnancy later on.
Yes.
So we should not be advising, I think, genetic testing for products in the index case, the first case, first of all. And secondly, how can we reduce this maternal contamination wherein the patient ends up paying for the microarray or something? What advice should you give your obstetrician or the person who collects? How can you prevent the maternal contamination?
So for your first question, why is the testing offered in the index case? So it's completely optional. Some patients now, because patients are much more educated and they have much more information on their phenotypes, they come and they ask and they say they want to know. If the patient wishes to know the cause, even if it's the first pregnancy loss, we can offer the testing. Secondly, that was the case of triploidy. But in case the fetus is anomalous, even in the first pregnancy, it makes sense to offer the case because we need to know what is the anomaly and why it is happening and what could be the recurrence risk factor for this. That is one option. But of course, in general practice, nobody offers the testing in the first pregnancy loss unless the patient is very keen on that. Or we usually see in doctor families, they're already aware of these things and they always go for the testing in such situations.
Because there are guidelines which are saying that do not offer, even if the patient is insisting, it is our duty as clinicians to, tell the patient that you might be just overreacting and it might not happen in the second pregnancy. And here comes the role of TLC and a lot of reassurance and counseling. So how can you prevent this maternal contamination and prevent that, loss of wastage of money?
Okay, so primarily during the DNC procedure, there is nothing much we can do because definitely it is a maternal fetal tissue coming in hand. Most of the placenta will be present and it is extremely difficult. So usually in cases of 6 to 7 weeks, we counsel the patient. The probability of informative result is hardly 30%. And ideally, it's preferable not to test because it may not be informative. But in some cases, if we are able to visualize the fetus by any chance, then we do offer the testing. From the OB-GYN side, there is nothing much we can do to avoid the maternal cell contaminations in the POC samples.
So you're
From
saying
the genetics lab,
70% cases have maternal contamination.
if the pregnancy is 6 weeks, yes, ma'am, the chances of us getting informative results is very, very low. So usually we tell the patient the probability of getting result is low. Let's not do the test. In 7 weeks, we have a so-so chance. So sometimes the fetus is clearly found easily.
Yeah.
The second thing is
onwards you see the embryo.
there is
the
possibility to see it.
Yeah.
And the second thing is at the site when you get the samples, better to rinse it 2 to 3 times with normal saline. So we get rid of as much of blood as possible so that there's no clotting of the blood because the sample will be shipped to the genetics lab, which might take a day or so.
In fact,
third thing,
fetus is expelled en masse. People have better chance of eating other than a curated sample.
Yes. And we usually tend to send as much tissue as possible because we usually try to dissect out the CVS. If we are able to see the CVS under the microscope, we will be able to get informative results. And this is much better way to do things at the genetics lab side. So if the genetics lab is able to dissect out the CVS and do the test for you, your informativity rate will be higher.
And the last question, if I'm allowed, before we sign off this session, that you said that in a phenotypically normal second trimester fetus, you do some pathological tests. You what are they exactly, and how does it help the next pregnancy?
Okay. So basically, when we do the complete histopathological analysis of the placenta, especially in cases of IUGR or IUD, we need to first look if there are any thrombophilia events which has triggered placental insufficiency. And we have had quite a few cases where the chromosomal testing has been normal and we have found a placental anomaly. And if it is a placental anomaly which has triggered the IUD, chromosomal testing is not at all indicated because your fetus is already structurally normal. The possibility of a chromosomal cause is less because if we are seeing deletions, duplications on chromosomes, there are large sections of the genes that are missing. Some 15, 16 genes minimum go missing or more than that. This will always have a phenotype associated. There cannot be a subtle deviation.
So, Dr. Fiona, you're saying that whenever it's a phenotypically normal fetus, think in lines of no chromosomal abnormality. Think in times of some placental abruption or something like that, which has caused the abortion.
Yes.
The second trimester is basically a no for chromosomal, right?
Unless there is, if the fetus is structurally normal.
Yeah. And then we've got such terrific scans nowadays. NT-scan, early anomaly scan. You have so number of scans wherein you can basically do a CT scan of the embryo nowadays. Dr. Fessy must be agreeing and Anu must be agreeing with me that I think we have to rationalize where. So your talk was fantastic, and you cleared many cobwebs, and you definitely have given food for thought as to where waste the patient money and where we can avoid that. Thank you so much.
Thank you.
I would like to comment. Sorry, hello.
Yeah.
Hello.
Yes.
Yeah. I was there. Hi.
Yeah, please go.
Hi. Yeah. Thanks, Dr. Fiona. Yeah, I also had a similar detailed us with all the things which we are not knowing also. And I had one of my patients who was having multiple abortions. Some of them were missed and one was a second trimester. And after that, she went for PGT with IVF and she had a successful pregnancy. And by chance, I don't know if there is any relation or not, she had a breast cancer later on. She came with the breast cancer also. It has some genetic issue or not, I have no idea. But that patient also had breast cancer later on. So, and one thing I wanted to ask you, we were talking about the tissue thing. So should we send the placental tissue also along with the fetus or we should send it separately?
So it depends on the gestational age. So if you're dealing with a gestational age between 7 to 10 weeks, it's preferable to send as much tissue as you get. So in the 10 weeks gestational age, we will be able to visualize the fetus. So the failure rate is low. But in 7 weeks gestation, it's better to send along with the placenta because we have had cases where we were able
that
to
will not contaminate.
No, it
will not contaminate. No?
Yeah, it will not, because we have to be careful at the genetics lab to not just take all the tissue. We dissect it, we rinse it with saline. So as much as possible, at your end, you need to rinse it out, avoid blood contamination. But at the genetics lab side, we will try to dissect out the CVS. So the fetal side of the placenta is more important in such cases. And then we can proceed.
For early pregnancy, you are saying that we should send most of the tissue that we have taken out.
Yes,
so that you will decipher what is.
Yes,
Okay.
it's better that way.
And
Because
one thing, like we were
really
talking
important
about.
visualize the fetus while you get the entire products. You will have all the tissues overlapping together. But usually at our lab, we see it under a microscope. We have a stereo microscope to dissect out all these things and then take up the tissue.
Okay.
Right.
One thing Dr. Monica said about the index case log, what we are doing nowadays, we take a consent that the patient doesn't want a karyotyping or wants a microarray or doesn't want a, because what is happening, sometimes they return back and then they say, some other doctor has said, why did you not do this? So in private practice, I'm also offering the patients and taking a consent, telling them that it is not a good decision that you should do it in the first case, but if you want, we can do it. Thank you, Dr. Fiona.
What I feel, Yashika, that we should have all these guidelines which are being made by ISAR,
Yeah.
ISRE, SRM, and these guidelines should be basically, we should know the basics, and you can have very simple printout of these guidelines for those Googling patients. So that at least they know that these are the guidelines, and here we are, sort of.
We tell them, we discuss with them, but they come later on afterwards.
Also, the thing is, in RPL, the guidelines are very confusing. Somebody is saying something, somebody else is saying something else. And also in the World Congress of RPL in Singapore, which just happened in January, they said that even one loss, if the patient wants to know and the patient is affording, why you could not give answers to the couple? It is criminal that patient is spending, ready to spend. They want a closure. Why would you give it?
No, I'm saying that don't do it for a patient who's insisting for it, but at least it's your duty to tell them.
Yes.
Might be just a futile.
Yes, that we should.
Yes.
We tell them, but sometimes because
for these patients you do everything.
Then they come and tell us कि आपने मुझे offer नहीं किया.
Everything.
So that should not be there.
I think it is always better to take a consent.
Yeah.
Thank you for the wonderful inputs by the chairpersons. It was a wonderful session. Thank you, Dr. Fiona.
Thank you, Anu, for the opportunity. All the best for
And by the way, my daughter-in-law is also Fiona. So while I was talking, I was thinking about her. So yeah, but thank you so much for having me. Thank you.
Thank you.
Thank you, Dr. Fiona. Thank you.
So coming to our next session, different cases, scenarios in RPL. For this, our moderator is Dr. Apurva Pallam Reddy. Yeah, she has done fellowship in reproductive medicine, and she has done her training of infertility in Belgium. She has done diploma in gynae endoscopy from Kiel, Germany. She's Yuva Orator ISAR 2020 and editor decision making in infertility, managing committee member of KISAR. Welcome, Dr. Apurva. Dr. Apurva, would you like to introduce your panelist?
I would. Please go ahead, ma'am.
Sure. So our first panelist is Dr. Shika Sechar. She's past secretary Vox and associate professor, Department of Obs and Gynae. She has published various research papers and has been an author for various book chapters too. Welcome, Dr. Shikha. Next panelist is Dr. Shivani Goel. She has done her MBBS and MD from AMU. She's consultant at Goel Hospital, Agra. Welcome, Dr. Shivani. Next panelist, Dr. Bani Singh. She is a consultant director, Saraswati Hospital, Varanasi. And she's ex-consultant Jamia and Hindu Seva Sadan Hospital, Varanasi. Welcome, Dr. Bani. So over to you, Dr. Apurva.
Thank you so much, Dr. Anu Kire, for having us here. That as we were even discussing this RPL, I just had to kind of put the patient who was.
Dr. Apurva, just a minute. Dr. Jitendra Behra, please show his CV.
Yeah. Yeah. You can tell that
I'm so sorry, Dr. Jitendra. I'm so sorry.
I think we have one more panelist also,
Dr. Jitendra.
There was one more, Dr. Kumari.
Dr. Jiten
Pushpa
Behra.
Kumari. Dr. Pushpa Kumari also is joined, I think.
And one more, yes, Dr. Pushpa
Yeah,
Kumari.
ma'am.
Dr. Pushpa, you are here?
Yes.
Yeah, ma'am. Yeah.
So Dr. Jitendra is consultant reproductive medicine and endoscopic surgeon at Future Fertility Bhubaneswar. He has done his fellowship in reproductive medicine from Kerala, former IVF consultant at SRM Chennai. He has 2 publications in Jogi and Treasurer IFS Odisha chapter 2024-26. Former consultant at ARMC, Aegis Hospital, Kerala. ISAR, he has received ISAR Youth Icon Award and ISAR Youth Brigade Award. Welcome, Dr. Jitendra. And our
Thank
next
you,
panelist is Dr. Pushpa Kumari. She is assistant professor in Madhubani Medical College, Madhubani, consultant Jogendar Memorial Medical Hospital, Darbhanga. She is director at Surgeon Dental College, Darbhanga, and Dr. KP Singh College of Pharmacy. Welcome, Dr. Pushpa.
Thank you so much, Dr. Anu, for having us. And can I share my slides, please? Yes. Okay. Can everybody see all the slides? If, Dr. Pushpa, you are I think you're muted.
Yeah, ma'am. And
Yes.
now unmuted.
Okay. Great. Okay. So we will have a very casual discussion as to, I honestly don't want to kind of talk too much about, what guidelines are saying or, that what, that a certain society is saying. Let's just understand and talk as to how we are managing our patients day to day, and that what we are doing in our practice and how we are going to deal with a miscarriage. As our previous speaker, Dr. Fiona, was telling, every miscarriage or every loss is very traumatic for a patient. We are seeing so many pregnancy losses or abortions, day in and day out. So sometimes, we feel that, we are used to it, and, that chalo theek hai, ye ho gaya, and, we will be able to plan for pregnancy later. But when we actually see 1 in 4 women are experiencing a miscarriage, and the rise of it is very alarming. So the first question that I would kind of like to ask is, when we know that there is a miscarriage, how do you kind of break the news to a patient? That how do you kind of do it? What are the tips that you would kind of like to share to our audience? May I ask Dr. Shikha to kind of pitch in? Ek point pe, we will just touch with everyone. Dr. Shikha?
Lighted home, the heartbeat is, and she's a primey, so she'll be distraught with that. And we obviously have to tell them that this is a thing, this might not, this will not continue, and this is a pregnancy loss you're going to do, and this is a condition which may not recur in the patient but can also set for further things. You may not need testing the first time, but later on, and most commonly they ask, what is the reason, ma'am? Kyun hua aisa, ma'am? Why did it happen to me? Then we have to explain there are umpteen number of causes. There are some causes we can test, some causes we cannot do. Apart from that, we have to provide TLC also, the tender love and care. And then we break this, and we can counsel them, help them having abort this pregnancy, and then supplement them, probably counsel them, and for the next.
Sure. Anyone else would like to add anything? Okay, so first things first, I think, never break the news over the phone, because, that आजकल बहुत common हो गया है कि that, they send you a scan report or, कहीं से भेज दिया है, and then they kind of say कि that अच्छा ठीक है, how is the scan looking? Is it looking good or not? So please always ensure कि that, you actually are seeing the patient physically, and only then kind of let them know. And I personally always get 2 ultrasounds done before I kind of declare any pregnancy as non-viable. मान लीजिए कि that even if it at 7 weeks I've done a scan and we see that there is no fetal pole, there is no heart rate, I always ensure and I tell them that okay, the pregnancy is not looking good. We will get a second scan done, and we call them back after a week to kind of reconfirm that there is no growth in this week. Never try wherein you feel that, there is no pregnancy, no matter how evident it might seem to you, because it's very possible that, later, sometime later, that कोई आके बोलेगा that हमने तो 8 हफ्ते में या फिर 9 हफ्ते में हार्ट बीट आया था, कि that हमारा तो 3rd month जाके फिर जाके हार्ट बीट आया था. So these kind of situations are very common, in practicality. So always ensure that you're getting 2 ultrasounds done before you declare a pregnancy non-viable. Ensure that you are giving them certain explanations. Because jitne bhi aap information us time pe aap patient ko bologe, they will not be able to kind of absorb all of it at that given point of time. The only thing that you need to convey to them is that this is unfortunate, but this does happen and there is hope. Itna hi hai. Don't give the entire jargon with respect to, what are all the tests and everything else, because at this point the patient is very vulnerable. So it's very unlikely that the patient will be able to absorb all the information. So, yes, Dr. Jitendra.
Ma'am,
Yes.
just want to mention one point.
Yes.
Sometimes, we have noticed that the patient will be not sure of dates. And the peripheral doctors also, they might have wrongly written okay, it is almost 8 weeks, and as you said, that should be considered to call the patient, see the physically, and take the proper history and do the scan and review after 1 week. Then you come to the conclusion.
Yes, yes. And
Ma'am, one more thing, ma'am. I have seen in many cases that up to 8 weeks, fetal heart rate does not come. And then what you have said, we used to counsel the patient, ask them to come for rescan after 15 days. And I have seen when I have given those patient HCG shots once or twice bi-weekly, then they get their FHR after 15 days. So it's a very good news. So I used to wait till 10 weeks. After 10 weeks only, I used to say, now it's viable or not viable. Seeing the structure of gestational sac, eccentric or non-eccentric, regular, irregular. On basis of that, I used to tell them to wait at least for 10 weeks. Absolutely. And I have seen out of 10 cases, I have seen 6 to 7 cases, they usually get fetal heart rate up to 10 weeks.
Sure.
And so what Sir has said,
yeah, that's also another important thing. I think trans-abdominally scan hua hai ki ya trans-vaginally scan hua hai, that also kind of makes a whole lot of difference.
Ma'am, one more thing. I used to wait up to beta HCG of 1200 to 1500. I also used to, I asked for beta HCG. I think it's slightly bit, they used to add expenses to their pocket, but I used to ask them for beta HCG, and up to 1200 to 1500 HCG level, I used to ask them to wait.
Raju,
then only I declare them.
मेरी को आवाज ही नहीं जा रही है.
Dr. Shivani, we can hear you.
Okay.
Yes. So,
I want to add one thing.
Yes, madam.
If the patient is having bleeding or spotting off and on, and she is coming after 4 or 5 days, and the fetal heart is not there, and the growth is not there, and you are giving costly medicines, dydrogesterone, SCG, and she is primary or second gravida. So sometimes the type of patients I am having here, they used to complain कि आप इतना पैसा खर्च करा रहे हो, बार बार अल्ट्रासाउंड करा रहे हो, बच्चे में ग्रोथ नहीं हो रही. तो मैम my second thing is कि if some clinical sense कि if it is not going to improve, then to the husband or in-laws, we have to give her guarded prognosis.
Yes, absolutely.
There are very less chances it will improve, but we have to wait. Sometimes it happens and sometimes it doesn't happen.
And this time duration will also kind of give them a mental preparation. In fact, the moment I know that, the pregnancy is not viable, we actually tell them that, they can stop progesterone, because it's possible that progesterone की वजह से ही उनका bleeding नहीं हो रहा हो, or, symptoms नहीं हो रहे हो, because they are also concerned that, सब कुछ तो ठीक है, कोई pain नहीं है, bleeding नहीं है. So as I said, I think that is a clinical judgment that we need to take to understand, that which is a a non-viable pregnancy, which is probably a delayed conception, and कि that 30 weeks के बाद वापस pregnancy आ सकती है. This, I think we need to kind of, use our clinical judgment. So,
इसमें ये जैसे हिस्ट्री फॉर डॉक्टर बन हिस्ट्री टेकिंग इज ऑल्सो इम्पोर्टेंट. जैसे प्रोलॉन्ग साइकिल्स जिनकी होती है, जिनकी डिलेड मेंसेस आते हैं, उनके साथ तो ये एक बहुत कॉमन ऑकरेंस है कि जो डेट पे उनका FHS नहीं आता है.
जी,
certainly should wait. पहले हमें एश्योर हो जाना चाहिए कि this is it. Then only we can break the news to the patient.
Sure. So the next, I think, very important question कि that एक अभी miscarriage हो गया है, termination हो गया है, now the patient has come back to you. She's had one loss. How do you start testing? क्या करेंगे अभी कि that एक miscarriage होके patient अभी आपके पास आया है कि that अभी आगे हमें क्या करना है?
कितने दिन बाद आया है?
1 महीने चलो.
6 weeks.
Yeah, so she is a 29-year-old female. She is married for about 4 years. कि that ये pregnancy आपका spontaneous conception हुआ है. 7 हफ्ते में जाके fetal pole आके heart rate आके 8 हफ्ते में miscarriage हो गया है.
We will go for proper history taking and other examinations like examination of the uterus. We can do it manually also. Size of the uterus, cervical incompetence, all these things we can rule out by our examination only. We can take history from the patient also. Since he is 29 years old, as you are telling, ma'am, she is 29 years old. It's too young. And if it occurs before 8 weeks, we can counsel patient that in first trimester, the maximum 60% of the miscarriages is because of chromosomal. So it may occur in next pregnancy. It may not also occur in next pregnancy. It's not sure it will occur also. So we will counsel the patient, and we will, if they are willing that I want extra other investigations to be done, we can ask about PCOS, we can ask about the history of diabetes, we can ask about hypothyroidism.
No. So all these are not causes. Yeah, all these are not causes for recurrent pregnancy loss. Okay, that we will get into that, discussion. But RPL के लिए अगर हम testing करना चालू करते हैं, the question is that are we going to do it immediately after the first pregnancy loss?
No, not after first pregnancy loss. And that I have told you, by examination, we can see if uterus size is okay, cervix is okay, then we can counsel the patient and we will ask them to take a gap. And then,
ma'am, it also depends upon the maternal age.
29 years, ma'am. Yeah, patient is 29 years.
Anxiety, and we have to counsel her. We can do baseline, ma'am, blood group, thyroid, and if there is any history, family history of any disease, past history of her any tuberculosis treatment, we should take a proper history. Examination and investigation will depend upon
मान लीजिए कि that tuberculosis का history है. How is it going to change our current line of action?
Yeah, exactly.
How is it going to change? मान लीजिए कि that family में किसी को diabetes है. मान लीजिए कि family को 3 बारी miscarriage हुआ है और फिर उसके बाद जाके pregnancy हुआ है. How is it going to change our line of action?
Ma'am, the patient history of tuberculosis.
Yes. हाँ, चलो ठीक है. Patient को भी tuberculosis हुआ है. How is it going to impact her current RPL outcome? Patient को pulmonary tuberculosis हुआ है, and when she was, let's say, 13 years old, she taken ATT, she's been cleared of it, she doesn't have any symptoms. अभी क्या?
Ma'am, we will take the proper history and write in her records. We will not investigate.
That is what I'm saying. That what is the history that is going to make an impact in us understanding what are the causes of recurrent pregnancy loss. So, like for example, smoking history. Do you know that, or the husband being a smoker? Yes, are the factors which will kind of help us. That is probably the only thing which will kind of let us know that because neither PCOS nor diabetes nor hypertension are causes for miscarriage.
Yes.
They might be causes only, the only hormonal abnormality which is responsible for miscarriage is thyroid. Apart from that, none of these other factors will actually impact recurrent miscarriage. Diabetes can, cause abnormalities in the baby, can cause preterm labor, can cause PPROM, can cause low birth weight or high birth weight, but it is never going to result in a first trimester loss. So that is again the reason why. So if
excessive caffeine intake, ma'am, caffeine intake, excessive caffeine intake.
Yeah. So हमारे ethnicity में, when you kind of look at our ethnicity, it's very unlikely, someone is going to have a large Starbucks kind of this thing which they are using on a regular basis. So which is why even in our history also we need to understand what are the factors that we usually look into, because these are the only parameters. And बहुत बार होता है कि that हम patient को ये factors पूछते ही नहीं हैं. Copper exposure, what is the kind of vessels that they are kind of cooking their food in, or the husband having paint exposure. घर में नया घर बना है, they have painted the house, and उसकी वजह से कि that they have had lead poisoning का exposure जो हुआ है, या फिर inhalational exposure जो हुआ है. These are the parameters जो हमें history में which can kind of help us in understanding eventual outcomes. But yes, these parameters कि that it only gives us an understanding as to आगे जाके कि that what's the cause, and what are the parameters that we need to change in their lifestyle before she starts planning for pregnancy again.
Even body weight is also a very important factor.
Definitely. That obesity in itself is such a uphill task that it's scary. Because, these days you can't say someone is obese also. You can't tell them to kind of lose weight also. And then at the same time, you can't deal with the, outcomes or the negative outcomes that kind of come with it.
Even my underweight also has the equal consequence.
Yes, and you will always have someone in their family, कि that जो कि उनसे ज़्यादा weight के थे and फिर भी pregnancy अच्छे से हो गया, फिर मेरे लिए क्यों हो रहा है, and these kind of questions and comparisons will set in. But so to kind of set the context for us to understand of when to start testing, I think again this is something which has to be driven by the patient and the couple. That yes, ACOG says, ISAR says, and RCOG says, and Foxy says, whatever it is, that दो pregnancy loss के बाद ही you categorize the patient as a RPL, and then you start doing your testing for RPL only after that. But it doesn't mean that you have to let the patient go through 2 more pregnancy losses and only then say that अच्छा हम testing तभी offer करेंगे. So you explain to the patient that of the 4 factors that we have mentioned, that genetics एक cause है, thrombophilia एक cause है, structural cause है, hormonal cause है, male factor. These are the only 5 factors which are detectable and treatable. Idiopathic parameters जो है, that you can neither detect it nor, उनका कोई standard treatment कुछ भी नहीं है. So these are the only factors which are detectable and which are treatable. So these parameters you kind of discuss with them, and then you tell them that, okay, these are the factors that could possibly be the reasons why you have experienced a miscarriage. And these are the factors that we can consider testing. तो वो parameters आप अभी test करना चाहते हैं, या फिर you can still, there is a good possibility that it's just because of genetics and that you might not really get any result by doing the other 4 parameters. But if you want to, we can still consider doing the testing. फिर आएगा अच्छा ठीक है आपका इतना cost है कि that you want to do it or you don't want to do it. Will always it always has to be the decision of the patient, because there is no harm. And coming back to the discussion of the index pregnancy, जो pregnancy loss हुआ है और उसमें genetic testing करना है कि नहीं. So our simple rule for that is, if you are not doing a DNC for the patient, then we don't do a DNC to get the chromosome or genetic tissue. उस चीज के लिए हम नहीं करते हैं. But if the pregnancy is already 8 weeks or 9 weeks and you are doing a DNA to terminate the pregnancy, to clear the pregnancy, तब आप जो निकाल रहे हैं उस चीज को टेस्टिंग के लिए क्यों ना भेजें? Because so it's as simple as that. So we never do a DNC to kind of acquire genetic tissue from the index pregnancy, But if you are already doing a DNC for a patient who is already, let's say, about 8 weeks, 9 weeks, or 10 weeks for the termination process, so for them, then we always recommend to doing the genetic testing. And if the patient, for the financial reasons, doesn't want to do the genetic testing, then we do not. I think this question we are going to skip because I think Dr. Fiona has extensively covered, so I don't want to do a repetition. So yes, okay. So what are the recommended thrombophilia testing? जो हम regular करते हैं, आप please go ahead. Anyone?
Yeah, ma'am.
Yes.
APLA test we used to go for APLA test.
Yes.
The diagnostic criteria is one from clinical and one from lab criteria should be fulfilled.
Yes.
The clinical criteria is one or more episodes of thrombosis of a vein, artery, or a small arteries. Second is one or more pregnancy loss of more than 10 weeks of gestation, and that is morphologically normal. जो बच्चा या जो fetus है, that should be morphologically normal.
Yeah.
Another is one or more preterm labor of less than equal to 34 weeks, and that is due to severe eclampsia or preeclampsia. And fetus should be morphologically normal. Another criteria is 3 or more losses of less than 10 weeks of gestational 10 week of gestation. These are the 4 criteria for clinical criteria. Another is lab criteria that should be done 12 weeks apart and on 2 occasions. First is for lupus anticoagulant, Russell-Weiffer we used to call it. Another is the anti-cardiolipin antibody and anti-beta-2 glycoprotein, for which we used to do, and it should be more than 40, some value is more than 40. And medium to high dilution, we used to do it in medium to high dilution. At least one criteria from clinical and one from lab should be fulfilled to say or prove that it is a thrombophilia. It is an acquired condition.
Sure. Abhi, how many of you empirically start heparin after 2 pregnancy losses?
Yeah, I used to start.
There is no need to kind of hesitate to kind of answer this. So coming back to the testing part of it, the only thing, the acquired thrombophilias are the only ones that you need to do your testing. You don't need to kind of do testing for your protein C, protein S, hypohomocystinemia. All of these factors, you really don't need to do a physical testing. It's only with respect to the acquired thrombophilias is what you actually do the testing. Aajkal we have an extended thrombophilia testing that has come, जिनका बहुत सारे parameters है, आपका ANA है, and that anti-neutrophils, and a whole bunch of extended testing also has come. We still do not know what is the implication of the extended thrombophilia testing, but essentially, as of now, whatever parameters we have, these are the factors which definitely have to be looked into. So the recommended factors are your lupus, anti-cardiolipin, and beta-2. The not recommended one or your hereditary thrombophilias, and the ANA and your natural killer cell testing. These are a maybe, that because it's like you've had 4 or 5 miscarriages and rest everything else is normal. There is nothing else that has come up, and only in those situations or circumstances you might consider getting a ANA or natural killer testing, and then understand to try and see how we would take it forward. So now moving on to our next patient, as we were kind of looking at the hormone profiling. So what are the regular hormone profiling which we would kind of recommend? मतलब हार्मोन प्रोफाइलिंग क्या ब्लड टेस्ट के हिसाब से आप पकड़ के चलिए, जो कि थ्रोम्बोफिलिया के अलावा what are the other tests that you would kind of recommend?
Thyroid.
Yes. Dr. Bani?
We will go for TSH, thyroid profile, anti-thyroid antibodies, and prolactin test, and we will surely go for rule out diabetes.
Yes.
HbA1c and all.
Yeah. So all as I mentioned that although diabetes in itself is not a factor alone for recurrent pregnancy loss, but it's always important for us to kind of ensure that the HbA1c levels are less than 6.5 preferably. And
Yes.
even if the patient is in over diabetes space, we would want, the sugar levels to be under control and the glycemic index to be well under control. And along with, your thyroid profiling, it's important to consider getting your anti-TPO antibodies also to understand the autoimmune factor
that
which
is.
is there. Dr. Jitendra, you would like to add anything else?
Madam, do you think vitamin D is essential for
I
doing as
thought
a routine?
let's do AMH first and then फिर उसके बाद vitamin D पे आते हैं. मेरा अगला slide
Okay,
है.
ma'am.
I have to
Okay.
tell all the audience that I intentionally did not give the panelists any of the questions so that we have an open conversation and open discussion कि as to हम क्या करते हैं कि that हम अपने OPD में क्या करते हैं, because this is not a lecture that we are kind of giving in college or for students. All of us are very well trained and very well educated. We are just having, sometimes it's always good for us to kind of know that चलो ठीक है, जो हम कर रहे हैं वो ठीक ही कर रहे हैं यानी सही कर रहे हैं.
Okay, ma'am.
वो चीज हमें
Okay.
पता होना भी जरूरी होता है. So this is these sessions, and Dr. Anu made it very, very clear कि that एकदम clinical होना चाहिए what we are having discussions. So before we move to AMH, let's just discuss, before we move to vitamin D3, let's just discuss about AMH. So जिनका अगर miscarriage हो गया है कि that in those patients, do you really recommend doing an AMH?
Actually, only in case of like elderly patient, if she is like above 30s and all, I used to recommend AMH, ma'am.
So I think the role for AMH here is that एक patient का अगर miscarriage हो जाता है, a lot of times their next question is that when can we start planning for pregnancy? That some want to start planning for pregnancy in 3 months, some want to plan in 6 months, some don't want to plan for another year. ये सारे factors आ जाते हैं कि that when do you want to start planning for pregnancy? So in these patients, I think AMH will give us an understanding as to how long their fertility is going to be. You cannot keep every miscarriage, you can't keep telling patients कि that आप अगले 6 महीने तक या 1 साल तक plan मत करो. And we do see day in and day out कि that patients come to us 4 years हो गए हैं, they've had 2 or 3 losses in this time, and then I am very upset कि that क्या कर रहे थे इतने time. They're like that, madam, they said कि that 1 साल तक आप कोशिश मत करो या 6 महीने तक आप कोशिश मत करो. 6 महीना डॉक्टर ने बोल दिया, 6 महीना हमने ले लिया, 1 साल हो गया. तो वैसे करते करते कि that their AMH, let's say 2.5 या 3 जो था, अभी गिर के अभी 0.7 0.8 पे आ गया है. So that probably the only space wherein AMH has a role. Otherwise, that AMH in itself cannot be a reason or an implication for a pregnancy loss. For example, a patient of 38 years who has an AMH of 0.7 and a patient of 28 years who has an AMH of 0.7. फर्क होता है कि that दोनों miscarriage हुआ है. The reason is because of age and not AMH. Yes, and anything else you would like to add?
So AMH is not recommended in testing, you want to say, Naman?
Yes, it's not recommended as a cause for recurrent pregnancy loss. It is only going to help you in understanding that how you are going to help the patient get pregnant, and how the patient is able to take subsequent thing, but it is not as a cause or a therapy for recurrent pregnancy loss.
So the comment made by Dr. Jitendra that we would do in old age patient or those maybe at the fag end of their reproductive span.
Yes. Only to kind of understand that how long do they have in understanding. And we have sufficient evidence wherein even patients with low AMH, when they have undergone IVF, there is no impact on their euploid or aneuploid embryos. It's been exactly the same. There's no difference.
Because at our government center, ma'am, we first do serum FSH and LH, even if we want to do, because AMH is still costly for them.
Yes. Why is it costly? AMH lab to lab is only $500.
No, ma'am, it's costly than FSH and LH. So patients who report to us, obviously.
What I'm saying is that the testing as a clinical, मतलब कि that जो क्या बोलते हैं कि that मतलब जो lab वाले करते हैं कि that वो most likely is about 2000 या 1500 या ऐसे कुछ होता है. But then कि that when we are actually doing it कि that जो test है कि that I think it costs only about 750 800 bucks.
Yeah, that is true. But we don't know why they price it at 2000, 3000. That's a monopoly they have.
So
let others survive.
Right. So FSH क्यों कर दे हैं?
Ma'am, that is the beginning investigation in a government setup, and it is like it's being done here. Abhi AMH जैसे it costs 3000, so it's difficult for some to afford. So we do day 2 LHFSH. Agar yeah, not for all, only for like in this case it is
What
not
information
recommended.
are you looking at?
Ma'am, if you are trying to see the ovarian reserve in this case,
why can't we do an ultrasound? Why can't we see it in an ultrasound?
You can do a AFC and see, yeah.
बस काफी है. There is literally no role of FSH and LH. आजकल as you know, madam was saying कि that आजकल scans मतलब इतने अच्छे हो गए हैं कि that and TVS इतना अच्छा हो गया है कि that there is literally no role of FSH and LH.
Alternatively, we can say that before going for AMH, I'll do an antral follicle count in my setup, in a government.
That's more than enough, you know, that we do a day 2 scan and we can kind of see in this thing. It really doesn't, you don't need it. See, my only funda, or rather I feel that the only funda for everyone for doing any testing is just one this thing. Just a second, sorry. Gunjan, तुम लोग कर लो कि that मैं अभी मीटिंग में हूँ. हाँ तुम लोग कर लो. If you get a testing done and उसका result के basis के ऊपर अगर आपका outcome change नहीं हो रहा है या line of treatment change नहीं हो रहा है, you should not get the test done. आपका AMH FSH मान लो 13 आता है, तो you know that the ovarian reserve is low. अगर आपका FSH 7 आता है, मान लो ovarian reserve ठीक ठाक है, how is it going to change your line of action?
Exactly. So AMH is also not needed. FSH, LH is also not needed. Serum.
Yes, that AMH will kind of let us know how long the fertility is going to at least last. But FSH is not going to tell you that.
Yeah.
That is the thing.
Okay.
So I'm generally telling that if you cannot get an AMH done, then you don't need to get an FSH and LH also done. You do AMH is only actually for the patient. हमारे लिए भी नहीं है, क्योंकि हम एंट्रल फॉलिकल देखते ही हमें पता चलता है कि दैट ये पेशेंट का रिजर्व जा रहा है. बट अभी वो हम पेशेंट को बताएंगे तो इफ यू आर गोइंग टू टेल द पेशेंट दैट द पेशेंट इज नॉट गोइंग टू अंडरस्टैंड इट. Only if in the AMH report when it shows low fertility, only then they are going to take it seriously. So I personally feel AMH is only for the patient. Antral follicle count is sufficient for us. But yes, it's definitely a much better test. And again, coming back to the fact, we are discussing in an RPL scenario. In an RPL scenario, doing an FSH and LH is not going to be of any significance. Yeah. And now vitamin D3. How many of you test vitamin D3 and how many of you just treat vitamin D3 deficiency?
I never test, but I used to give vitamin D because I know all like 90% populations are deficient of vitamin D.
Yes, absolutely. And
give the vitamin
so instead
D.
of giving such a
Dr. Shivani, yes, please.
Ma'am, I have never told patient to get tested. It is very costly test, but we can prescribe vitamin D for 3 months and then a break for 1 month, then again. And if she is having RPL or infertile, so vitamin D will help.
Absolutely, absolutely. Dr. Bani, anything you would like to add?
Ma'am, I also don't go for tests. I usually prescribe vitamin D.
Perfect. Dr. Shikha, anything?
We don't go for those tests, but yes, we supplement it.
Yes. So I think vitamin D3 is again one of those medications wherein it is going to kind of have an impact on the entire reproductive outcome of the baby per se, that it will definitely have an effect. So all you need to do is that ask the patient when is the last time that they have taken vitamin D3. If they have not taken vitamin D3, then once in a week you can give it for about 12 weeks. Give them 12 tablets, ask them to finish those 12 tablets, and that's about it. Uske baad, then you can kind of either give them a couple of months gap and then restart the therapy, or you can ask them to take it once in a month continuously, till they achieve pregnancy. It's always very, very important that you kind of ask them when is the last time they have taken vitamin D3, especially in case if they have been taking treatment from a couple of doctors in the past, because it's very likely that, if they have taken it and again we are giving, sometimes occasionally it's possible that they might develop toxicity also. So please ensure that you just ask them when they have taken D3 last. So from a hormonal profiling point of view, that definitely look for thyroid profiling, sugars and prolactin. What is not really recommended is the insulin evaluation, ovarian reserve testing, luteal phase insufficiency, or homocysteine levels or androgen. And vitamin D3, as I said, that it's always better for you to treat it rather than testing it. So let's move to the structural component of RPL. So a 26-year-old lady with a 4 centimeter intramural fibroid, not intending the cavity, who's already had a miscarriage in the past. So we're not talking about, first time pregnancy, they have come to you, they've already had a miscarriage in the past. Now what? चलो 5 centimeter पकड़ के चलते हैं. I'll make it little more, tussle करते हैं कि थोड़ा इधर उधर दोनों. Who are the lab surgeons in the house? Dr. Jitendra wants, he's already excited.
I will definitely do.
मुझे तो पता ही था. बाकी?
Yeah. I will do.
Ma'am, if it is not indenting the cavity,
but she's had a miscarriage in the past.
It can be
So
due
you
to
want
other
to
causes
another
also,
thing to
ma'am.
happen.
there may be other reasons of the
Other
miscarriage.
causes.
सब normal है कि DFI normal है कि that AMH
Everything normal. And when once the second happened, now when you explain the patient that this may be the reason and I will remove, the patient will again,
which is what I'm telling.
put a question on you. Then
from a practical point of view,
yeah, exactly.
The patient आपके सामने है कि that हम क्या करेंगे. It's because this is something you see day in and day out. कि that that there are abnormalities and that there is that all your कि क्या बोलते हैं कि that guidelines and everything are not going to come into play here. कि that you are going to be responsible for this patient का pregnancy. आगे का मतलब she is planning आगे के लिए कि that क्या करना है. So what are we going to do?
First, we will try to counsel the patient that your uterine cavity is absolutely normal. So there is no need of doing anything. And still, if the patient party is insisted of doing something, then we can go for office hysteroscope. And then we can counsel the patient according to that.
Ma'am, she is quite young, only 26
Madam,
years old.
Instead of doing
and
office hysteroscope, you can do 3D scan.
हाँ, scan also 2D, 3D scan also.
नहीं वो सब करके ही हमें ये आया है कि that intramural है. So the gap between the endometrium to the fibroid capsule and the endometrium is about 2 mm. Okay, it's a see now again, as I said, let's get back to the physiology part of it. Indenting fibroid तो सभी निकालना है. There is no question about it. We know for a fact that उसको निकालना ही है. आपका यूट्रस का मसल का थिकनेस कितना होता है? One side का wall is about 2 centimeters and the other side wall is about 2 centimeters. आपका anatomically अगर हम सोचते हैं, so it's a 5 centimeter fibroid which is present. Indent भी नहीं कर रहा है. Embryo कहीं ना कहीं तो implant तो होगा ही. तो फंडल रीजन में अगर एम्ब्रियो इम्प्लांट हो रहा है, प्लेसेंटेशन हो रहा है, इफ द प्लेसेंटा इज काइंड ऑफ ट्राइंग टू एक्सटेंड और कि दैट वास्कुलरिटी डेवलप हो रहा है, तो देन इट विल गो इनटू द मसल ओनली ना. तो देन देयर इज अ पॉसिबिलिटी कि दैट you see why we are not able to come up with a study is कि that मान लीजिए कि that the fibroid that is there is on the fundus, or let us say is on the anterior wall, या कोई भी इस पे है, and the embryo is not implanting there, कोई और wall पे implant हो गया, so then that pregnancy will continue. But let us say the embryo is implanting on the wall that has the fibroid, then it is going to affect pregnancy. How is it not going to affect pregnancy? And this is the counseling that we should be able to do for the patient. Always, always do not take decisions for the patients. You have to tell them that this is the probability, that uterus का आपका 5 sides होता है, that या फिर that 3 sides implantation का होता है, and there is a possibility that इस side पे अगर implantation हो, तो then that repeat miscarriage हो सकता है. If the embryo implants somewhere else and the placentation is happening safely, then it's possible that कोई miscarriage ना हो, और वो हमारे हाथ में नहीं है. Then you leave it to the patient to take a decision, because this is how physiology works. Do not go by what a certain guideline is telling, that we have read all of this and that we know how the math works. So we should be able to kind of take that decisions, because as madam said, metformin था नहीं, फिर metformin आया, फिर metformin नहीं रहेगा, फिर इसके बाद metformin होगा. Every 10 decades, the evidence is going to change. And that is, that we will not be able to kind of always make our clinical decisions exclusively on this thing. You have to kind of be able to use, our clinical expertise also to a certain extent. That way, I'm not saying that a patient who comes to you with a 4 centimeter fibroid without a miscarriage, you go ahead and operate and do a laparoscopy for them. But then if you were in that situation, in case if it was your daughter or your daughter-in-law who was in that situation, इतना laparoscopy में डरने की क्या बात है? ऐसा नहीं है ना कि that chemo, and then it is going to kind of have some kind of effect. So have that discussion, have that conversation with the patient, and then let them make an informed choice.
Ma'am, this is only the first abortion which has happened.
Yes.
And ask you do the operation, उसके बाद madam 100% मेरा बच्चा नहीं गिरेगा.
No, there is no guarantee. What I am telling is, if you don't have the discussion with them, if you tell them that अरे ये तो fibroid से कुछ नहीं होगा, there is no problem with it, कि that आप आराम से next pregnancy plan कर लो.
मैडम सेकंड क्वेश्चन पूछेंगे, ऑपरेशन के द्वारा मैडम ऐसा तो कुछ नहीं होगा कि हमें बच्चा ही ना हो दोबारा.
नहीं वैसे कैसे
होगा? नहीं होगा. 100% ऑपरेशन के दौरान ऐसा कुछ नहीं होगा जिससे कि that आपका that much confidence you should have in your surgery, na?
Exactly.
It's not like that. It's things which they ask.
Which is why I'm telling. वो तो पूछेंगे ही, वो तो 100% पूछेंगे. The only complication with the procedure is that the anesthesia risk in itself. That is the only concern with this thing. Otherwise, that when you are confident that अच्छा 4 centimeter का नहीं 10 centimeter 12 centimeter का fibroid भी हो, that we will be able to kind of do it, wherein we are not doing any harm. So I'm saying that include the patient in the conversation, include the patient in the discussion. Do not nullify the factor that ये मत बोल देना that चलो ठीक है कुछ नहीं है. That is what I'm saying. I'm not telling you that you should not do. I'm telling you that tell the patient, discuss with the patient. And there are patients who decide that they don't want to do it, which is all right. And there are patients who decide that they want to do it, which is also all right. जो भी होगा that we need to give them that assurance that आप जो भी decide करेंगे उस चीज में we will continue. ऐसा नहीं है that मैंने तो आपको बोला था fibroid है, आपने operate नहीं किया, अभी देखो दोबारा miscarriage हो गया, तो करके you can't blame. There's no blame game. So please involve the patient in the decision making is all I'm saying. So yes, that I think all kinds of, obviously that with regarding to the structural abnormalities, septum, it's a definite parameter wherein we have to kind of correct it. And again, when we come to fibroids, as I said, there are strict guidelines wherein there is black, there is white, and there are whole shades of gray that is there in between when it comes to, especially when it comes to fibroids and when it comes to structural abnormalities. So yes, involve the patient. DNA fragmentation index, how many of you do it? Because AMH नहीं कर पाते, DFA कैसे कर पाते हैं?
Madam,
Actually running in a project here, sir, ma'am, so we do Y microdeletion also and DNA fragmentation.
Okay.
Because the project is funding that.
My God. AMS, they are not funding or
AMH is a general test. If you do an ISMR project, obviously now AMH is old for them. They believe in newer things like Y microdeletion and DNA fragmentation. So they
Ma'am, we can go for DFI because in male factor, it is in RPL, it is very much one of the common cause.
So I'm obviously from Bangalore, that so we're in a metro space, but I just want to kind of understand, जो लोग semen analysis नहीं कराते हैं, वो लोग DFI के लिए कैसे राजी हो जाते हैं?
Ma'am,
in RPL cases analysis is mandatory, ma'am. Without that, तो कोई treatment कहीं भी नहीं होता, whether it is a गांव or शहर or anywhere.
But is it free of cost? DFI and microderm deletion.
So yes, I think DFI is a definite factor, and I think ये चीज every single time we're doing the counseling, it's very very important for us to kind of emphasize that male factor भी होता है, male lifestyle का भी impact होता है, diabetes especially कि that बहुत सारे men में जिनका diabetes होता है उनका DFI naturally elevated होता है. So these factors, that people who drive bikes or that who are traveling a lot, who are exposed to construction working and so on and so forth, बहुत सारे parameters की वजह से उनका DFI elevated आ सकता है. So it's very very important that we emphasize that it is a factor and that it has to be tested.
Especially in the case of RPL, ma'am.
Yes.
Now when it's coming more and more in vogue and people accepting it, that there might be a factor with male factor.
Sure.
They need to get investigated.
Absolutely. So I think we will just quickly wrap up regarding the treatment factors of it. Again, for genetics, we've already had an extensive discussion. So we will just look into thrombophilias. Yeah. So anyone get that? Dr. Pushpa?
Yeah.
Yeah. In thrombophilia, should I read or should I tell my own?
आप जो करते हैं, जैसे थ्रोम्बोफिलिया मान लो कि आपका पॉजिटिव आ गया है, एप्लो पॉजिटिव आ गया है.
We used to start with low dose of aspirin and low molecular weight heparin, and sometimes I also use enoxaparin also, depending on the weight of the patient. I used to give. In low molecular weight heparin, we start as soon as the fetal cardiac activity comes, we start low molecular weight heparin, 5,000 to 10,000 per day, subcutaneously and per day. And in some cases, I used to monitor frequently with APTT, and that should be within 1.5 to 2.5 times the normal value.
So
And
if we are using unfractionated heparin, then we need to monitor it. But otherwise, if you're using a low molecular weight heparin, you either give a prophylactic dose of 40 or you give a therapeutic dose of 60 mg. And
till pregnancy, till delivery.
Ecosprin, I used to start even if a patient gives the history of RPL. So before planning for pregnancy, also I used to start ecosprin, depending on the how many miscarriages. That is
that you have to do. That we have to do.
Yes, yeah, sir. I used to start according to the how many miscarriages she has, or कब वो मेरे पास आई है. Few patients came to me after 8 and 9 miscarriages. So in that case, as soon as they start planning for pregnancy, I used to start ecosprin and keep it, continue it even after she conceived, and then low molecular weight heparin or enoxaparin, as you have said, ma'am. If they are less than 50 kg, I start with 20 milligram, or more than 50, then 40 milligram I used to start.
Anything else, Dr. Jitendra? You want to?
Ma'am, one more thing. I sometimes use steroids also. Sometimes.
Madam, sometimes I used to give HCQ also 200 mg twice daily, and IVIG I never used, but because it's costly also a little bit. But when the high profile patient, very rarely I used to give that 200 mg per kg body weight. And once it will be positive, so once in once in 21 days, means 3 weeks, for almost like 12 weeks pregnancy, till 12 pregnancy.
Yeah. So
Ma'am, one more thing I want to ask from you. We use, ma'am, immunoglobulin every 21 days. So we use
I am immunoglobulins ke again, you know, that they don't have too much of a role. That, you know, only IVIG that I know that, you know, of a particular brand that you're kind of telling about, that uska as such that there is no significant evidence उस चीज के बारे में बोलने के लिए that all your, you know, बाद में I will show the slide that, you know, all your GCSF and, you know, that immunoglobulins and all of these that they're all you know, side actors that, you know, sometimes they make a difference, sometimes they don't make a difference that, you know, जब आपका hero नहीं चल रहा है तभी जाके, you know, you kind of fall back for all these
sometimes intralipids also.
Yes, that bus otherwise you have to kind of stick to this thing. But yes, I think HCQS is a very important factor because we work very closely with immunological centers wherein they do extensive testing because from an IVF point of view, from a recurrent implantation failure point of view, also we kind of do it. So HCQS is something that which has a real good impact. The only point is it has to be started at least 2 months prior to the pregnancy. आप index pregnancy में कि that आप वो चालू नहीं कर सकते or it's not going, so you can't start HCQS after the patient get pregnant and experience a miscarriage and say that HCQS has not worked. It needs to be taken at least 30 days to 60 days prior to the pregnancy for us to be able to say that it has impacted it or not. So, which is why I think when you are using HCQS, it has to be always in conjuncture with your immunologist and understand that if this particular patient is going to have any benefit from it or not. So I think thyroid again.
But how much dose you are giving? HCQ 200 BD
yeah,
or
200 mg in certain patients based on how their hormonal profile is. It's either once a day or twice a day.
Madam, sometime I have seen like infertility IVF specialist, like sometime we used to, after like 12 weeks, we used to send the patient to refer to the respective gynecologist for the further antenatal checkup. And we have started this one, like after 2 hours we are starting this low molecular heparin, and immediately they will stop it once they will reach them because they will find like nothing is recommended why you are giving. But to be very frank, there is some immunological role of the
100%.
low molecular weight heparin. So the message has to be conveyed that it should be continued. It should not be stopped.
Which is why that if someone else has started the heparin, I never stop it. So whoever has started the heparin should be the person to stop it. It should always be like that because it happens a lot wherein, you know, let's say the patient travels from somewhere else and, you know, comes to us, or, you know, that from us they have traveled and gone somewhere else. We always say because, you know, they have observed the patient for a long duration of time. They have seen the patient for a longer duration of time. Just 1 second, sorry. Okay. So it is just that whoever has started should be the person who should be able to kind of stop it. I think it's just that simple. We'll not get into the space of, you know, prophylactic heparin use karna hai nahi use karna hai. We'll not get into the space of it. But quickly, I think 2 more slides and let's just wrap it up. You know, progesterone, I think there is a lot of back and forth going on, but everyone is using it. I am using it, that we are using it. So we'll again not get into it. All of these, you know, as I said, are all, you know, side characters that jo aapka hai, there is no giving away. Like for example, using metformin in PCO patients, that hai ki nahi hai, you don't know. So you go by a clinical judgment. Obesity hai, you know, there is a lot of weight gain, you know, there is a lot of you know, acanthosis nigrans present, you know, that the hormone parameters are all over the place. So for that patients, you definitely put them on metformin. But vitamin D, I think, is the only thing which definitely has a role. Likewise, with respect to you know, uterine anomalies also, septum is one thing which is definitely recommended. Arcuate uterus, I think if you're already doing a hysteroscopy, if you see that there is an arcuate, please resect it. You know that 3D में अगर हमारा arcuate दिख रहा है, जरूरी नहीं है कि that जब आप जाके resect करो. But then if you cannot do any endoscopy if you are not prepared for handling any kind of outcome. Like for example, today we did an ectopic pregnancy, जिसके लिए बोले थे कि that bilateral hydrosalpinx है करके ultrasound का report आया. But when we went inside, it was bilateral endometriotic cysts that was present, and that extensive adhesions were there, and there was a fibroid also of subserosal ISA, but 5 centimeter का fibroid भी था. So we removed everything. We removed the fibroid also, that we did endometriotic dissection also. We removed the ectopic also. So it's not going to be possible that आप बोले कि चलो मैं ectopic करने के लिए गया, मुझे ectopic की मैं करूँगी और मैं आ गया. So we should, especially when you are doing invasive procedure, we should be able to kind of do everything. So yes, don't do a hysteroscopic resection for arcuate, but hysteroscopy किए हो, दिख रहा है, resect करो. Agreed?
Agreed.
Sabhi log, only you and me are saying that agrees. The other ones are not very confident. Dr. Shikha?
Arcuate, yes, if I'm doing a hysteroscopy, definitely I'll do. But per se, for an arcuate, I'll not do.
Yes, so we do not need to kind of do, 3D. If you're finding an arcuate, it's not required for you to kind of go ahead and do it. But yes, if you're already doing hysteroscopy and when we see it, please go ahead and resect it. Likewise, I think with respect to fibroids also, submucosal fibroids, definitely remove. Intramural fibroids, you have to take the decision. Subserosal fibroids, definitely no. Polyps, yes. Cervical incompetency, that it's something, it's a second trimester loss. So again, we will have to look into it. So for the last slide, oops. Okay. Yeah, quickly, anyone wants to give a take on this? Dr. Shivani?
Ma'am, I don't use prophylactic heparin, and antioxidants also no. Vitamin D I give, and progesterone I usually give. Sometimes nahi, usually if there are more than 2 abortions, then I give ecosprin also, and not the other things, not steroids, not.
Sure. Dr. Shikha, what do you use? What you don't use? Any of these?
Yes, ma'am, I used progesterone, that is true. Prophylactic LMWH I do not use, but I agree with madam's point that if she's having 8 losses, 9 losses, still testing mein kuch nahi aa raha. In that case, I do add a prophylactic heparin maybe. Rest of the therapy, immunoglobulin I'm not using. Immunization therapy is also not using. I also don't use steroid in my practice. Maybe I'll try HCQ now after listening to you and Dr. Jiten.
Yes.
That's it for me.
Dr. Bani?
Yes, ma'am, as per the same thing, progesterone I definitely use. SCQ अब हम भी start कर सकते हैं.
Very good, great. So it's one take home point. Dr. Jitendra, anything that you use in this?
Ma'am, actually prophylactic low molecular weight heparin I'm using. Antioxidant, anyway, I think all of us are giving, even if it is no RPL also. And LEAT, I only used to do for recurrent implantation failure. IVIG, I'm not routinely giving, hardly like some patient, once in 100 patient. Glucocorticoids, I'm routinely giving, madam. Intralipids, no. GCSF, no. And endometrial scratching, I think there is no point of doing scratching for this RPL.
Sure.
RPL, yes.
Anything else, Dr. Pushpa, that you would want to add?
No, ma'am. I have told you, I use low molecular weight heparin. Antioxidant also, I uses it. And lymphocyte immunization, I don't use. Intravenous immunoglobulin, I use in 50% of my cases. Glucocorticoid, selective cases. Intralipid, I have not used. GCSF, not used. Multivitamins, I used to give according to if they want, they do kuch ma'am, kamjori hai ye wo, to then I used to get endometrial scratching. I have not done.
Yeah. So the only point I would like to add here is that especially for PCO patients, that when we are monitoring, it's very important that you check what their day 2 endometrium is, endometrial thickness is. Because a lot of times PCO patients have a certain amount of hyperplasia which is present, which in itself can be causing poor implantation, and which in itself sometimes can be causing miscarriages. So in these patients, actually curating the endometrium and removing the hyperplasia or giving them norethistérone, progesterone therapy for a couple of months can improve the endometrial implantation rate and can improve chances of pregnancy. So it won't come under endometrial scratching, but yes, we will have to kind of look specifically for PCO patients regarding their endometrium thickness on the day 2 to understand if there is any hyperplasia. Yeah, so I think on that note, yes, we have multiple modalities.
Vitamin D, right?
Definitely, vitamin D, though, we've already put our thumb on it. Agreed, and that's not our side actor. That wo, that literally हमारी hero की मम्मी पापा है. So that you can't not take it per se. So thank you so much. Thank you, Dr. Anu, for inviting me here today. And, thank you so much to our wonderful panelists. And, I'm so sorry I decided not to send you the, presentation, but this is the reason why we've had such interesting discussions and, such wonderful and up-straight conversation. Thank you, everyone, for joining today.
Thank you. Thank you, ma'am.
Thank you, madam. Thank you, Anu, madam, for giving us the
You must visit me, and that please drop in at any given point of time. I would be very, very happy to host you all.
Madam, your as usual, your panel will be a panel or talk. Everything will be super duper hit. So there is no doubt about it. Thank you, ma'am.
And it was very practical.
Yes,
We'd like to send the same invitation to everybody. Welcome.
Ma'am, you are a wonderful moderator.
Thank you so much. Thank you so much, everyone.
Thank you, ma'am.
It was a wonderful panel, Dr. Purva, or
Yes,
I think everybody is going with so many take-home messages. Just one thing I wanted to add, like जब आप first question में discuss कर रहे थे ना, history of pulmonary COX.
Yes.
So sometimes, like in Eastern UP, na, COX is quite prevalent. So in 80% of cases of pulmonary tuberculosis, genital COX coexist.
Sure.
So I think in these cases, we should inquire about this history, because this genital COX can be a cause of RPL.
Sure. Does just genital COX cause RPL, ma'am? I thought that it will result in infertility per se, or increase in risk of ectopic. That would it really cause recurrent pregnancy?
Yeah, ma'am, I have seen, and many a times diabetes and COX coexist. The patient is very cachexic, and she used to come with the history of 2-3 abortions. And when I send her to physician and when ATTs started, I have seen 3-4 patients, they conceive.
Absolutely. So I think the point, the whole point is that, like, for example, I think in Kerala, endometriosis is very, very rampant. So likewise, that जो भी हमारा region का ethnicity के हिसाब से, whatever are the parameters that we feel might increase your chances of, miscarriage or, primary infertility per se, because we always ask tuberculosis history for someone who's having primary infertility per se. But now I think, with this input, maybe because, we also do get a lot of patients who are from North or UP, जो Bangalore में आए हैं, यहाँ पे काम कर रहे हैं. So maybe we can definitely incorporate this input also in our RPL questionnaire.
So it was wonderful to have you all.
Yes.
Thank you.
Thank you
But
so much.
not the least, TLC is very important, tender loving care.
Absolutely.
Thank you, Anu ma'am.
Thank you. My pleasure.
Ma'am, if you allow me to, shall I give
Sure.
thank you note? Yeah, thank you. I would like to extend my heartful gratitude to our esteemed all speaker who have contributed to to make this event more successful. Especially thanks goes to Dr. Mohan Kamath as well as Dr. Fiona D'Souza and absolutely Dr. Apurva for sharing her vast knowledge through diverse case studies on RPL. Also, thanks to all chairperson and panelists for their valuable contribution throughout thoughtful and for this session. And also deeply gratitude to Dr. Amit Patki, Dr. Bakshi, Dr. Anu, Dr. Facey for their continued support, and heartful thanks for our today's chief guest, Dr. Kamini Rao, and guest of honor, Dr. Sujitra Pandit, for gracing us for their presence and for impactful scientific session. Let's look forward for many more such enriched and engaging events together. Thank you very much. Thanks to all.
Thank you so much. Thank you, everyone. Good night.
Thank you, Dr. Purva. Thank you, Dr. Pushpa, Dr. Anu. Thanks.
Thank you. Bye. Good night.
Good night, ma'am.
Yeah.
Good night.
Good night.